Hi, Clerk. How are you, Keith?
Hi, Chair, not too bad. I'm hearing you fine. I'm not seeing a picture.
Okay. Okay,
That's
that
it.
should be that sorted, yeah.
So that's us live from now, Chair.
And we have Minister and Co on the line, do we?
Minister's available, yep.
Okay. Okay, well, so I declare the meeting open to the public online members, and I'd like to welcome all of our members who are participating by video conferencing in light of the request that people reduce contacts and that we facilitate that safe distancing in terms of COVID-19. So I'd also like to remind members about the protocols regarding the use of electronic devices. Any members today, any apologies today from members, Clerk? Or
No, I've received none, Chair.
thank you. And members aware of any apologies? No, thank you. Okay, members, with your permission then, members, I suggest that we move straight to the briefing from the Minister and come back to the remainder of the meeting and the chairperson's business after that. And that's in light of the fact that the Minister this morning needs to be away at 10:45 for an executive meeting. So that's why we're starting early, and I think to get the maximum benefit of that time, we move straight to the Minister's briefing and question and answers, if members agree.
Agreed.
Yep, members agreed, thank you. Okay, so I will go then, and could I ask for the Minister and the officials to be brought into the spotlight? Okay, so I'm seeing Minister there anyway. I don't see any of the other. Yeah, I'm starting to see others coming now. So I'll just check your sound first, Minister. Can you hear me okay?
Yep, I can hear you, Chair, if you can hear me, yep.
Yep, hearing you there. And we're also joined by Peter Jacobson. Peter, can you hear me okay?
Loud and clear, Chair.
And Peter's the Director of Surge Planning and Health Service Transformation. Also, Gearóid Cassidy, Director of Primary Care. Can you hear me, Gearóid?
I can hear you, Chair. Can you hear me?
Yep, hearing you fine. We have Alistair Campbell, who's Director of Hospital Reform. Alistair, are you hearing us?
Yes, thanks, Chair. You can hear me okay?
Yep, loud and clear. Paul Kavanagh, HSCB, Interim Director of Planning and Commissioning. Can you hear us, Paul?
Chair, we don't have Paul on the call yet, but we'll bring him up if he comes in.
Okay, and we'll go on then to Mark McGuckin, who's Director of Disability and Older People. Mark, can you hear us okay?
Can, Chair, yes, thank you.
Yep. Okay, so listen, a large and a very experienced panel, which is great, but also which will require, I suppose, tight management, Minister, in terms of succinct answers and maybe directing. If you could direct to whoever you think, or if members know that they have a question that they wish to direct to a particular member of the panel, then that's fine as well. But if I could just ask everyone to stay on mute when you're not speaking, to avoid feedback, and also ask members to keep their questions as succinct as possible, and also panel so that we can work our way through as many questions and answers as possible. So I'll go back to yourself, Minister, there. Well, firstly, I should say you're all very welcome to this morning's meeting. Thank you for coming to committee today, and we're looking forward to the session at what is once again a very difficult times. And I do want to, at the very outset, reiterate those public health messaging, asking everyone to get your vaccine or your booster when you're called up, taking responsibility for in terms of your social distancing, wearing face masks in congested settings, and adhering to all of the regulations and guidance, and to do that as a minimum, actually, and do more if you can, because this is a very difficult time in terms of health, but also in terms of our health services and the pressure that healthcare workers are under. So, Minister, I'll go back to yourself if you want to make some opening remarks, and then we'll take it from there.
Thanks, Chair. And look, in regards to the officials that have asked to come along this morning specifically, because we were looking at winter pressures, so I've brought a wider range of officials as I think will be necessary to make sure we can keep committee members updated. So again, Chair, thanks for the opportunity to update you this morning on, as you said, the pressures that are currently facing our health service this winter, and the planning that our health and social care system has undertaken to prepare. You'll be aware that on the 22nd October, I made a written statement to the Assembly outlining the wide range of measures that the health and social care system is taking to prepare for this up and coming winter. I won't rehearse the entirety of that statement because of time pressures today, but I'd like to take just a few minutes to run over some of the key elements before opening to questions. I said at that time, and it remains the case now, that we are most likely facing into the most difficult winter ever experienced by our health and social care system. And that will be on top of a summer and autumn period like we haven't experienced before, because the level of our unscheduled pressures has made the past summer feel like an extra winter period. We've seen hospitals over capacity and patients waiting for admission. So when coupled with a stubbornly high plateau of COVID-19 patients, we shine a light on the likely scale of unscheduled pressures that are facing the system this winter. And Chair, to manage these pressures this winter, we're taking an integrated approach to surge and winter planning, and we'll continue to deliver services across the whole of our health system, from primary care to secondary care and social care, because surge and winter planning has been informed by the modelling of unscheduled pressures, COVID-19, and other likely pressures such as winter flu. So alongside my written statement back in October, I published the Trust's winter plans, and these plans set out in much detail the planning at an individual trust level and are available on my department's website. And in those trust plans, they include the acute bed modelling, which has been underpinned by a number of assumptions in relation to unscheduled pressures and COVID-19. However, modelling doesn't represent predictions, and therefore we're planning in context of a highly uncertain environment, especially now with Omicron, because our approach will be to monitor pressures against regularly updated modelling to ensure that those actions can be taken in a timely manner. Our trusts have all been taking a number of mitigating actions to create further acute bed capacity, and those actions include increasing the bed stock, improving discharge and flow, and reducing delivery of elective care. Chair, the Health and Social Care Board in itself will play a key role in managing the system, actually on a regional basis. For example, critical and respiratory care will again be managed regionally through our critical care hub, and also the board will continue efforts to manage unscheduled pressures, and that will ensure we take that best use of available capacity, because this regional approach served us well during the severe COVID-19 surge that we actually experienced last winter. And a key focus for this winter will be the management of unscheduled pressures, and as members will be aware, the pandemic, together with the wider system pressures that we are facing, has led to a situation where each of our major emergency departments are now operating significantly above capacity. As some members are aware, a dedicated unscheduled care management unit has been established to monitor activity, identify and share best practice, support change and improve flow, and specific attention is being placed on improving timely discharge. The department also published the No More Silos action plan that will support our emergency departments during the coming winter, and up to 21.2 million will be invested in this financial year to deliver on those 10 key action points of that plan. That includes key initiatives such as Phone First, urgent care centres, the Timely Discharge Initiative, ambulance handover bays and hospital at home. And I'm confident that these pressures will support the trusts in managing the high levels of unscheduled pressures expected this winter. And whilst they recognise the huge pressures facing our emergency departments, without all of these measures, the position would be much worse. And Chair, I have on many occasions made it clear that I want to see every part of the health and social care estate used to maximum elective capacity. This will of course be challenged in the context of the likely winter pressures, but I'm determined to ensure the system delivers as much elective care as possible. And much work has already been done to undertake to identify those green sites where designated elective surgery hubs will continue plan surgery safely and sustainably throughout the winter. And that's to ensure the hubs operate effectively, efficiently, and a specific and targeted workforce appeal has been launched to ensure the appropriate staffing is in place. GPs and primary care will play a crucial role, as well as helping to manage additional service demand and keeping people safe this winter in the communities that they serve. And figures show that GP teams are carrying out almost 200,000 patient consultations every week. And we know that general practice will also play a central role in the delivery of COVID booster and flu vaccination programmes. And in recognition of the challenging winter period ahead, I've recently announced a package of £5.5 million to support service delivery in primary care. But the impact of additional winter pressures on an already strained social care service is also of a significant concern. The sector is facing the impact of COVID-19 at the same time as having to deal with significant pressures on staff recruitment and retention. And again, my officials now have been engaging with and listening to the main social care providers to establish what specific additional support is required, actually to alleviate the ongoing difficulties and to develop immediate solutions to support the sector over the coming months. And as members will be aware, I responded to the need for an immediate action by announcing last week a £23 million funding package for domiciliary care and care home staff. I am confident this funding will facilitate increased capacity across the social care sector this winter. That's what it's envisaged for. And that £23 million package was developed through long-standing and detailed engagement with the sector. And I'm grateful for the collaborative approach which will support the sector through what will be a difficult and pressurised winter period. The funding will enable employers to offer improved terms and conditions, better training and career progression opportunities, and rates of pay. And it's my hope that this will provide an incentive to those wanting to stay within the sector and indeed attract new staff to the sector with actually the aim of increasing capacity. There's immediate work to be done given the crisis that we find ourselves in, but there's clearly also a need to address issues in the long term. And the work of the reform of adult social care review will inform the long-term reform of that sector. And I do hope, Chair, to launch a full public consultation on the reform of adult social care actually in the coming weeks. And I know it's a policy that the committee will rightly be very interested in. Our COVID vaccine booster programme, again, is an integral part of our efforts to manage pressures during this difficult winter. Vaccinator teams are looking after care home residents and staff in a planned programme, and wider Northern Ireland booster programme has now begun for those eligible. And you'll be aware, Chair, that following the recent JCVI advice, the rollout will continue to be on a phased basis. And I would encourage, like yourself, to strongly encourage all those eligible in Northern Ireland to get vaccinated and to get their booster jabs when their opportunity arises. And that's something each of us can do to help protect ourselves and our health service. Finally, Chair, our health and social care workforce have been at the front line of the battle against COVID-19 since day one, and they're exhausted. But they keep going, and we must do everything that we can to continue to support them in the delivery of care of the population of Northern Ireland. And my department is working closely with the Trust to ensure there is sufficient capacity within the system and will continue to do so throughout the winter period. And that includes through continued workforce appeals and international recruitment. The health of our existing workforce is also of paramount importance. And again, I remain committed to continue to develop and enhance psychological and wellbeing supports for staff through our regional workforce wellbeing network. Our health and social care staff remain our greatest asset. That's who make the health service. That's what the health service is. And it is ultimately the dedication, commitment and hard work of all our staff that is going to see us through this winter. Chair, just in summing up, that was a very brief overview of some of the measures that we are putting in place to manage the up and coming winter period. But make no mistake, and I make no apology for repeating this message. We are facing into possibly the most difficult winter that our health and social care system has experienced. But we're not without hope. If we all play our part and do everything that we can to limit the spread of COVID-19 to protect our services, we will get through it. And Chair, I'm happy to take questions or comments from yourself and from members.
Okay, thank you, Minister, and thank you for that presentation. I do want to say that I did welcome the additional funding for the domiciliary care. I think that's hugely important. I do have some questions in with you around further detail on that, but I'm looking forward to receiving that bit of further detail. I'll probably pick up more or less there. We finished off around the workforce, Minister, and I suppose it is fair to say I don't think they've probably been ever under such stress for an unprecedented length of time and put under so much pressure. And I think, there are certainly issues with morale, and we know there are issues with people leaving and potentially burnout, and lots of other issues with staff being off sick as a result of COVID, as a result of looking after children or family members who have COVID or contact with those. And it does concern me that we lose 8 ICU nurses, given the particular speciality. We're also aware that Musgrave Park Hospital, for example, is a very dire situation in terms of some of the nursing situation there. So rather than a rehearsal of the problems, which is not really beneficial, my preference would always be in terms of teasing out solutions, or are there ways to gain further support? One of the things I raised at one of our earlier meetings this week was around the issue of intervention interviews rather than exit interviews. So where someone indicates that they're going to leave, that we would set up a dedicated system to speak to those staff to see, can we bottom out what it is that's causing them to make this decision, and is there anything that can be done in terms of changing work patterns, changing, across a range of areas. Is that something that could be looked at as a matter of urgency, Minister?
Thanks, Chair. And I think one of the things I've found since coming into this role and working with you is the synergies that we often come up with. And maybe at a further session, it might be worth getting a briefing. One of the things that I've actually done is establish a nursing and midwifery retention initiative. It's been co-chaired by Karen Lee and Karen Hargan, are actually the two co-chairs. Again, this was basically in talking with RCN in regards to how we could actually start to challenge that. You'll be aware, Chair, that I did say, I've said a couple of weeks ago that I wanted to separate recruitment and retention and look at them as two different sections. So we've actually started to do that. And in regards to appointing those two individuals, Caroline is actually just retired as head of our clinical education centre, and so she has that experience. Karen Hargan is currently our director of human resources. There isn't anything specific that I have tasked them to do in regards to intervention interviews, but you've said it this morning, Chair, I'll pass that thought process on to them, because it is about keeping people in the system. And if we can do as much, and that would involve engagement at a local level, as well, I suppose, at a strategic level through yourselves, through Workforce Directed.
Okay, and linked to that then, is it correct to say that within Agenda for Change there is a recruitment and a retention premium built in there? Is that something that's going to be considered by Caroline and her team as to how that might be maximised?
It's not, as I say, Chair, I haven't set them any specific criteria. I just asked them to do the piece of work and let them come back to me in regards to that. In regards to retention premium, it's not something that we've widely discussed in regards to how we retain staff or staff specifically. It's been referred to in certain areas as golden handcuffs. It's not something that we've taken forward as a policy initiative at the minute, but again, their work remit was left quite open in regards to what they can actually bring forward as recommendations that we could implement, even if it's not for a sustained period, even if it's just to get us through the next 3 to 6 months. It's something that we continue to do, but Chair, always conscious of that. It comes with a budget ask and a financial premium that we have to seek from elsewhere currently.
Yeah, and actually, I think even though it's part of the jigsaw, and it takes all these parts of the jigsaw, I suppose, to try to make a difference, but very often it could be more to do with the work pattern or just the pressure someone's under in another way. So maybe that's the other thing I will add to that, just for you to consider, really, as much as anything else, is could that team go back, say, for the duration of COVID, for those who have resigned, and I'm not sure what the numbers will be involved there, but would it be manageable to go back to those who have resigned since COVID and approach them and ask them, is there something now that has changed that they would consider coming back to the service? That may be something that, or indeed, if you're looking at some of the COVID light sites, if they have particular vulnerabilities or family members with vulnerabilities, maybe now they would reconsider that the COVID light sites are part of the picture.
It's not something that they've asked this team to do, because I wanted them to do a short, sharp, focused piece of work, but it's definitely something we could look at the longer term. In regards for our workforce appeal, that we put out in regards to local sites and additional elective care, those individuals that you're specifically talking about, Chair, were and are eligible to approach for them, so that if they have concerns, or as you say, clinically vulnerable people at home that they don't want to be coming into previous COVID exposed sites, there is an opportunity for them to come in through the workforce appeal. But again, a targeted outreach and ask and approach to them is something that we could definitely consider.
Okay, I'll move on then, because I'm keen to get to members as well. The other thing I wanted to raise with you today is we have done, obviously, earlier in the week, our meeting with the Royal College of Surgeons on the winter pressures, and we're very focused at this point on winter pressures and the impact that will have on surgeries. Is there anything you can update us on in terms of the regional waiting lists? And also, is there progress on that around the regional waiting list? And also, are there any initiatives now as a result of multi-year budgeting now coming forward? Are there things now that can be done differently in terms of waiting lists that we have struggled with before with single-year budgets?
Chair, again, there will be opportunities come forward with multi-year budgets, but we have to wait to see what that budget is before we can make any commitment on how we're actually using it. In regards to some of the waiting list initiative work that we have taken forward, we are seeing actually numbers coming through that we're using through our independent sector. Also, GPs taking up some of the more lower acuity stuff as well, where we're actually seeing them taking up numbers. Through the waiting list initiative programme that we started connected to the elective care strategy, I think we've seen roughly in the region of 81,000 people. I don't know, Paul, from the board. Paul, if you maybe want to come in and touch on that, if possible. Paul, we're not hearing you, sorry.
Still not hearing you, Paul?
Chair,
can you hear me now, Colin?
Yes, yep. That's you now, Paul. Yeah, go ahead, please.
Sorry, Colin, I'm having technical difficulties this morning, but hopefully you can hear me now.
Yes, we're hearing you, Paul.
Yeah, grand. Sorry about that. I mean, as the Minister says, a considerable number of people being seen. I mean, we really have looked to every place that we possibly can look in terms of looking for capacity for our elective surgery, because we're very conscious with our elective surgery that we have, certainly with our high priority patients, patients who have been delayed much longer than we would wish. So we've been working hard to get those patients seen, as well as looking with our other opportunities to deal with some of our more routine patients, Colin, but again, patients who have waited a long time. So we've been looking to the independent sector within Northern Ireland. We've also been looking across to particularly to Dublin in terms of accessing some surgery with there as well, and indeed looking beyond. And we've been drawing in additional providers as well. So we've seen a lot that is happening, and we've been fortunate as well through the Minister to gain some additional funding as well. So we're hoping that over the next number of months we'll be able to see quite a number of additional patients to have surgeries that is one very high priority surgery for some, and also long awaited surgery for others. So I think the progress in that has been good, and we're keeping that under close review, and obviously keeping the Minister closely apprised.
Thank you, and and I think it's welcome that, and I think we should be very actively looking at. Actually, I done a number of visits yesterday in the south with some. I met with St James Hospital, and I met with the Children's Hospital in Crumlin, including the paediatric cardiology specialists. And they're very keen. They're very keen to work. One of the things I did, and this is by way of a comment, I'm not going into detail on this, but one of the things that was very striking to me was where they were doing their own recruitment, they were able to fill their posts an awful lot quicker. And I think even in terms of the ongoing pandemic situation that we're in, anything that can be done to free up recruitment should be considered as part of the work that's ongoing. But I'll just mention that. The final one for me then is again briefly on dentistry. And Minister, I'm aware of serious issues, certainly within the Southern Trust, and I believe this goes much wider. It's my understanding that there could be over 200 children, and maybe more at this point, waiting for emergency treatment, dental treatment, and the logjam in the system seems to be a lack of anaesthetists. And many of these children are suffering quite badly, and I have some of them in direct contact with me, and I've failed to be able to get anything kind of progressed on it. But is there a way to look at that dentistry? And I know dentistry has had particular problems, but given the very, very poor oral health inequality situation, oral health that we had already, I'm concerned that this is adding to that in a way that's going to add significant suffering to young people in particular. Are you aware of that issue, Minister? And is there something in terms of a focus on anaesthetists and potentially maybe even with some of the other jurisdictions that we could look at trying to free up some of those surgeries? I think most of them are fairly routine, but they can't be done without, obviously, the anaesthetic.
And I think it goes back to the paediatric anaesthetists as well, and the challenge that there's come there. We have set up, and we didn't mention it in the last, it's just some of our mega clinics that we've been able to run. So we have run some dental mega clinics. We've also run some paediatric dental mega clinics through some of the trusts at a regional level as well. I don't have the numbers specifically to date, Chair, in regards to that. But again, if it would be useful, we've just appointed a new chief dental officer. Maybe worthwhile getting the committee just even a quick brief in regards to where she is and the work that has been done there, because Caroline has a great insight and a great working relationship with BDA, and we've had some great engagement with them in regards to next steps and how we can get back to enhanced capacity and additional capacity over the next few months.
Okay, and I see a hand up from Paul. Were you looking in on that point briefly, Paul?
I suppose just to add to Minister's comments, I mean, we're working actively on this issue. It is a very challenging issue, Colin, as you've described it. We're looking to see whether or not there are other sites in Northern Ireland that could take some of the paediatrics, the children waiting for dentistry, needing GA, needing a general anaesthetic, and seeing how we'll actually resolve that. So there's an active piece of work to resolve that at the moment, Colin.
Okay, thank you. So I'm going to go to members then in the order it indicates. And I had a hand up from Carol earlier, which came down. So I'm going to go to Carol, then Paula, Deborah, Colin, Pam, and Alan at this stage. So I'll go back to Carol and Colin. Carol, Lana Riley, the Hall, Lesh and Kest.
Thank you, Chair, and thank you, Minister and panel, for coming this morning. I'll ask all my questions at once, and it's up to yourselves in terms of which way you want to answer them. I'm concerned that, we've known about the winter pressures from June, certainly from July, and the workforce issue seems to be hitting the headlines for all the wrong reasons. So really, the Chair's touched on the recruitment and retention, but one of the issues I think we need to get a bit more detail on, certainly about the consideration of rebanding some of the staff to keep them there. And the other real concern I have is that we're going to end up privatising health and social care because of the heavy reliance on the independent sector and bank nursing. So that's my one question. The other one, Minister, is, and you'll be aware that I and other members have raised this, but certainly given the amount of funding, and we all welcome that's gone into social care, certainly one of the issues that is really pressing, will the recognition payment be made before Christmas? Because that's something not only people are relying on, but certainly, given the fact that you said yourself that a lot of the staff are exhausted, certainly in social care, that is the case as well. So just about that. And then one of the issues that we had really is around the heavy reliance on emergency departments. A lot of people are still having difficulties getting access to GPs. Even for things like repeat prescriptions, even ringing through to surgeries can't get answered. Is there a way in which, people who have long-term illnesses or life-limiting illnesses or just, have been on certain medications, that they can get them without having to go through their surgeries? I know some are doing it, but others aren't, and that's the ones that we're hearing about. And then my last question is in relation to the neurology. We received certainly a lot of briefing in this, but it seems that the report will be with yourself, Minister, certainly in the new year, with a hope that it's published before March. I'm just appealing to you to ensure that happens before you leave office, because it's important that whole debacle, but certainly the outcome of the public inquiry is published and certainly stood over, because we need to all learn lessons from what happened there. So, Chair, I'll leave it at that. Thank you.
Thanks, Carol. So I'll go back to you, Minister, then, if you want to kind of address those or allocate them out.
Just to go through them, Chair. In regards to the neurology report, Carl, as quickly as I can get it out, I'll publish it. I'll not give you any commitment because I have to receive it. I have to get through Maxwellisation and all the rest of it. But you know, that it was transformed into a public inquiry with legislative powers for a reason. So as soon as I can do that, we will. In regards to the privatisation of the health service, you know me well enough. Not in my watch and not under any duration or direction would I ever want to travel there. If you get back to the elective care strategy published in June, the target was to get us back in a place in 5 years' time where we're actually balancing in-house capacity against demand. Now that is reliant on the utilisation of private capacity to get us there, and that's where we'll need. There'll always be a need for some, but it shouldn't be the majority or the driving factor in what we do. I want our National Health Service back in the footing that it's meant to do. Our reliance on bank nurses is, you know, and I've repeated this many times, our reliance on bank nursing is because of the understaffing that we have in nursing in regards to where we are. So the 300 additional training places per year that we started when this place came back in 2020, you know, we'll start to see them coming out in the next 12 to 18 months. And then that's 1,325 training places for 3 years. So hopefully that starts to redress our current workforce balance and the necessity in regards to that. In regards to the workforce and the rebanding piece, again, is the retention and recruitment strap that is set up specifically for nursing and midwifery. Again, Caroline and Karen are looking at a wider scope there as possible. In regards to then the £500 update, look, as of the 30th of November, I can update members. We have now, this is specifically in care home and domiciliary care. We have processed and paid 161 applications that we've received out of 257, and that's to the value of 4.7 million, covering just shy of 8,000 people working in our care homes and domiciliary care homes. So as quickly as we can get, and BSO, you know, a pay tribute to them and the ability and the time commitment to returning these applications around in. So we've just shy of 8,000 people paid and 4.7 million out in that sector. In regards to community pharmacy, dental GPs and that side, which are being handled through the board structure, we have claims of nearly 9.5 million. So those are being processed and worked through at the minute. So again, to make sure that we get the validation and the audit trail for that money, but still get it out as quickly as we can. That's the commitment I gave, and I'm grateful for the people that are working through that. In regards to GPs and the update, as I said, you know, we have put in that additional funding. And maybe, Chair, if I could bring Garode in just to talk about the specifics of that, if that's okay.
Certainly.
Yeah, thank you, Minister. Thank you, members. As Minister said, I mean, we recognise, obviously, there's been significant pressure on access to primary care services. The roots of that, I mean, the pandemic has had a big effect on that, but I mean, service has been under pressure for a while before that, and we've known there's a need to. We've been working to try and alleviate that for a number of years. The most recent information we have is that, I think Minister referenced, I mean, even at the minute, with the kind of infection control measures that are in place, primary care is still dealing with approximately 220,000 consultations per week. Almost 50% of those, the most recent figure was 49% of those are face-to-face. So the telephone first system is allowing more people to be seen and have access to their GP and to the kind of GP services more widely than would otherwise be the case. For most people, it's allowing them to get same-day access, which is not the case before. I mean, people would have historically have to wait for a while to get their appointments. Now, we recognise that people are having it's very frustrating and very difficult when people are trying to access the service and either the phone's not getting answered or they have to make multiple calls. We've made investment last year and this year to try and improve that situation. Last year, primarily around just increasing the physical infrastructure for telephony. This year, part of the 5.5 million that Minister announced back in October, part of that was around boosting capacity to make that service work better. So in effect, it's a small amount of it was on the kind of the infrastructure. More of it is around additional administrative staff and resource to make sure that phone can get answered, to make sure that when people are accessing their repeat prescriptions online, that those are then getting picked up from the queue and processed. But I mean, it's a difficult situation. I mean, one of the things I think is important to say is that, you know, the move to kind of the telephone first kind of triage in primary care, I mean, it's been definitely accelerated by the pandemic, but it is something that we were moving towards prior to the pandemic. I mean, as a response to just rising demand. So I think that, you know, it's a system that is in place that is working well. It can still work better, and with evidence, we are working hard and working with practice and through the Health and Social Care Board to make sure that we do make the improvements that can be made.
Gerard, apologies, Gerard, I'll have to rush you along there to get around all the members. If there are additional information, and we do want to hear it, Gerard, absolutely, we do want to hear it. If there's additional information, maybe forward that on. And if questions don't get picked up, maybe members, we can forward those on via the clerk and get the information back.
Happy to answer any questions or to come back at your convenience.
Okay, thank you. Was there anything else additional in Carol's end that needs a quick pick up or maybe return to in writing, Minister?
Yeah.
I think we covered the 5 points, but if there's more detail there, we'll have a look at what was asked for.
Okay, thank you. So moving on then to Paula. Go ahead, Paula, please.
Thank you, Chair, and thank you, panel, for coming to committee this morning. My first question is in relation to some of the initiatives that have been introduced across different trusts to ease the pressures. And I'm talking about Home First, Hospital at Home, Enhanced Care at Home, Enhanced Care Response Team Pilot. And I noticed from the report that only some trusts have some and others don't. And I'm just wondering when we're going to see uniformity across all those 5 trusts for those. My second question is in relation to the 23 million that was provided for domiciliary care, and very much welcomed, Minister. I think it's very timely. However, when I met with a provider in the Western Trust yesterday, there's still a lot of uncertainty as to how that money is going to be rolled out. As you are aware, a lot of them are hanging on by their fingernails with huge vacancies, and the figures just don't add up at the minute, because a 20-minute call and then the next one's 12 miles away along rural roads is just not efficient and doable. They're actually making a loss. And the third question is in relation to the vaccine certification. Minister, I've been contacted by a number of constituents who are elderly, don't have smartphones, and are really, really struggling to navigate the system. I don't think they're the type of people who would try to defraud or try to gain entry somewhere when they haven't been double vaccinated. It's just very confusing for them. And I'm just wondering if there's going to be any latitude for people who are elderly and who are maybe struggling to get out to see loved ones this winter in hospitality settings or art settings. Thank you.
Thanks, Paula. Just in regards to the Home First and the our Hospital at Home and other initiatives, we are seeing, I suppose, different trusts moving at different speeds with different parts of No More Silos work in regards that's really to capacity and where they have, I suppose, the ability to move quicker. It is about getting those bits that we can do actioned as quickly as possible. So, the Hospital at Home, as you say, previously known as acute care at home or even enhanced care at home, I think one of the things that No More Silos actually shown was a number of trusts doing something very similar, but calling it very different things and sitting under different directorates. So what we're actually doing under Hospital at Home is, and again, it goes back to that regionalisation that we talk about, is to make sure there's a consistency of approach. There's a consistency of what people can expect in each of those models, and I think it's one of the bonus isn't the right word, but it's one of the transformations that we've seen over the past 20 months when we have seen, trusts really coming together to look to each other to get from best practice, what are you doing that works, what are we doing that works, and then supported by us centrally, but also supported by the board as a way of, can we apply additional funding, or we can support additional funding, in some of the regards to some of the hospital at home. I'm not sure who would be the best, and maybe they just look to Peter or Alistair just to touch on some of the specifics on that when I finish. In regards to the 23 million domiciliary care package, Mark's on here in regards to that. We have written out to all trusts so they can contact providers to make sure they know exactly what that money funds and what it will fund, but it'll bring Mark in regards to that. In regards to vaccine certification, you'll be aware, in regards to it's unlicensed hospitality isn't covered at this minute in time, but they are moving in that direction. So a vaccine card will suffice at present, or a downloadable paper copy is applicable at the minute, but we're keeping all that under review, as you're aware. So I don't know, maybe Chair, just quickly, if we bring Mark in the 23 million, and then maybe either Alistair or Peter on the home first side of things.
Yep, just briefly, please, gentlemen, if you can. Thank you.
Right. Thanks, Minister. Just to reiterate what the Minister said, the board been working very closely with board colleagues, who in turn have been working with assistant finance directors across all trusts. The board rolled out to trusts last night to detail exactly where the 23 million should be funded, which rates will be uplifted, and exactly how it was to be rolled out. So the letters should be issued from trusts in the very near future to the providers to explain exactly how this will be rolled out, and what rates are being uplifted, and where the money should be rolled out to. The conversations with the trust as well were around how they would deliver the money and the mechanisms for that. So the conversations have happened to iron out any potential in-house issues, if you like, in getting the money out, and the letters should be issued from the trust very quickly. It is our intention that money will roll out to the providers this side of Christmas, and that's why the conversations have happened with the trust assistant finance directors before the letters were issued to the trust. But work is in train to get that money out as quickly as we possibly can.
Thank you.
Mark? Sorry, I maybe very briefly pick up the no more silos point. So yes, the long-term ambition is to move to a regional position in that it's the same service in each trust. But I think we recognise that there will always be some local variation. But I think the important thing is that service users' perspective, that it looks and feels the same when you access the service, and that's definitely what we want to get to, Paula. It will probably take some time to get there, and it will take additional funding as well across some of those, because they're all in different places. But absolutely something we'll be working towards.
Thank you.
Okay, thank you.
All right, thank you, Paula. And going to Deborah then. Go ahead, Deborah, please.
Thank you, and I want to thank the Health Minister and the panel for coming today to the Health Committee, which is a very useful briefing, because obviously we hear an awful lot about winter pressures from our constituents. A lot of the questions have been asked in terms of what I was hoping to ask from some of the members, and I just want to reiterate, and I suppose we can't shout it from the rooftops enough in terms of the measures that we need to put in place in terms of hands, face, space, and getting vaccinated is important. Yesterday we heard from Dr. McBride and Professor Young, and I took from the meeting that in terms of doubling down on those efforts to ease our winter pressures as well in terms of COVID cases that may be coming in. And I'd be encouraging everybody to get their vaccinations, to get doubly jabbed and get your boosters. However, COVID passports have been billed as one of the tools to protect our hospitals and ease winter pressures. What detail and what specific scientific evidence was provided, and how effective is a COVID vaccination certificate in stopping the spread of COVID? What has been the experience elsewhere in terms of cases? Has it reduced the cases? And indeed, in businesses where the measures were introduced, how have they been impacted? What other measures were also discussed? Was it, are we focusing on trying to bolster our vaccination programme? Are we trying to focus on getting domiciliary care sorted out? What other measures were discussed as well in the executive? And then I have two very final questions, but if you could maybe deal with that one first.
You did rightly there, Deborah. For somebody that run out of questions, I thought you did rightly. Go ahead, Minister.
Thanks, Chair. No, Deborah. Thanks. Look, the questions you're asking are topical, and I think that's why I think it was useful for Dr. McBride and Ian, our Chief Scientific Advisor, to provide that briefing to the committee yesterday, and I think they covered a lot of the specifics that you've actually asked in regards to the evidence in the scientific papers that are available on the department's website under the COVID certification. In regards to what other measures were taken, and you'll be aware as well, when the executive published its autumn and winter plan in regards to what measures could be looked at, there were a number of initiatives there. Now, the executive decided we actually covered point one and 2 at its last couple of meetings. Point 1 is really about reinforcing the message, making sure, as you say, we double down on the things that we know that work, and that's the hands, face and space side of things, but also promoting the vaccine programme as well. But in regards to the second point, in regards to that, was looking at the COVID certification and how that could be introduced and how it could be actually looked at. If you do look what else can be considered, and again, it's there in the autumn and winter plan that the executive published, it's come back to things like social distancing, and those other measures as well that we had used through the entirety of this pandemic. Now, where we're coming from, also from a health point of view and recommendation, is that where we are in utilising those first 2 measures that are in the executive's autumn and winter plan is where we should be now, so that we don't have to go to the further steps that are needed as well, because those have more severe implications both societally and economically on the entirety of our society as well. So that's where we came from in those recommendations. In regards to what else we can do and what else we are doing, I think you yourself said, in regards to domiciliary care, we've put that £23 million into the system. Now, that's investment that should have happened a long time ago. That's a sector that has been underfunded and ignored for a number of years, and that's why I believe it's under the pressure that it currently is now. I think it was actually Chair going back maybe even 2 years ago at the start I referred to, and I think it was a question from Jerry Carroll referred to it as the Cinderella service, because it's something that had kept below the stairs. We knew it worked, we knew it was there, but we never brought it into really into the spotlight of where it needed the support or the recognition that we've given it. And I think COVID enabled us, unfortunately, to do that and provide those additional supports. So that's the domiciliary care package. That point also helps us, Deborah, with the flow through hospital, which is important as well. And I know of a lot of officials on here, but I think it's important when we're talking about winter pressures that it's not just one single part of the system. This is the entirety of the health service has to respond, because we work as one system. If you're waiting in ED, it's because there's somebody in the bed. It's because they haven't got discharged. It's because they haven't got out the other end. It's because they didn't get vaccinated at the start. Their bed's been taken up by somebody who hasn't been vaccinated. They should have been. So it's about this entire system approach. So it's all that coming together of all those things that we know actually that works. In regards to COVID certification, it's something that was in the executive's winter plan as an option to take forward. The executive has agreed to do that, and I'm conscious, some of your media commentary in regards to the steps that I have taken, but I've taken those on the majority vote of the executive, supported by the scientific advice. And you received some of the briefing on that yesterday at the session with Ian and Michael, and I think Liz.
Thank you. I suppose, in terms of the COVID vaccination, certificates, it's only right that we provide scrutiny to help inform ourselves and to inform the public as well. And, I am inundated with people who are getting in touch in relation to this, not, may I add, and to be frank, from the anti-vax lobby. These are businesses who have concerns as to what this will mean for them in the run up to Christmas. And I'm just wondering, in terms of that, yesterday I heard from Dr. McBride and Professor Young, who were saying that on its own, COVID passports have a minimal sort of impact, but obviously with a range of the packages together. So I'm just wondering, are we adding something with a minimal impact onto the range of things, the toolbox that we have? And, really I would like to drill down into terms of Scotland has introduced this, Wales and places like that. are we seeing the impact that we need there? And will we see that in Northern Ireland in terms of vaccinations, in terms of it stopping the spread? That's really what I would like to know. But also, just if you don't mind, just to be quick, because I know time's short and I don't want to take up too much time. But the other thing,
time's actually up, Deborah. Deborah, time's actually up. You'll have to be very brief. You'll have to be very brief for the question. The minister will have to be very brief, and they need to hand on the information.
Yeah, well, it's just if you can give an update on the current volume of regional complex care or regional complex cancer and urgent surgery as well, just if you can. Thank you. Sorry about that.
No, you're grand, Deborah.
Thanks, Deborah.
But, in regards to the regional, as RPOG, we call it Regional Programme Operational Group, which do now look at the level of intensive surgeries that are listed across Northern Ireland. We do now prioritise and work through a regional level, and that's at those type 2 or level 2 severity cases. Maybe Paul has an exact figure in there in regards to he can supply that. But look, in regards to the certification point, and it's a bit, and we've said this before, as part of a package, as part of a basket of measures. It's not standalone. When Wales introduced it, when Scotland introduced it, it was part of a wider package as well. And that's, where we're coming forward in this. And that's why when you look at the autumn and winter plan, it's those first 2 measures that are coming together at this time, this point in time. I hope we don't have to go to 3 and 4, because that's the next step to where we have to increase, and go back to some of the restrictions that we had seen in the past. But again, as your point, as the chair's point, as we said at the start, if we can get people to double down and use the things that we know that works, means we don't have to go any further. And I really hope we don't. So hands, face, space, vaccination, should that be first, second, third, booster or flu, please get it. Paul, in regards to numbers, can you give a very quick, or will we come back and write?
Sorry, Minister, I was trying to see if I could find it quickly, but I don't have it to hand, so we'll need to come back, unfortunately.
Minister, I have them if that would be helpful.
Oh, thanks, Al.
Yep, go ahead, Alistair.
We have about, I think, only 66 patients priority 1, but in total for priority 2, which we split into priority A to priority D, depending on how time critical they are, there's about 4,800 at the minute waiting. But we are prioritising the capacity that is available. I think it's also worth saying just that the Belfast City Hospital is operating very successfully as a green site for complex surgery. And I think it was mentioned at your RCS briefing about the need for PACU, which we have at the City Hospital, and I think actually is the envy of other parts of these islands, because it is working very effectively. So there is some good news on complex low position, continues to be very challenging.
Okay, thank you. Thank you. Yeah, thanks, Deborah. And as part of that discussion yesterday with the CMO and CSO, actually, I did say, and I personally think it's almost the COVID certification scheme is almost a minimalist approach, in a sense that we're essentially trying to establish that you don't actively have COVID before you go into a crowded setting where you don't necessarily need to be for a few days until you're clear. And it's not just the vaccines, there are other elements to that. But I do think there's a need to communicate that message better. I think the vast majority of people out there understand that, but need empowered, in a sense, to push back on people who are some of the, and I accept Deborah's point that it's not all people who are anti-vaxxers, but I do think there's a need to enforce and reinforce the messaging on that issue out there as well, as part of an overall package, as you say, Minister. But anyway, I want to go on then to Colin. I have Colin, Pam and Alan. Go ahead, please, Colin.
Thanks very much, Chair. Thank you, Minister, and the team, and thank you very much for all of the work that you're doing in very, very difficult circumstances at the minute. It's really appreciated, and the whole wider health service team. My question is going to expand and build on one that's already asked, given that the first 4 members have asked you about 200 questions already. So it's inevitably going to build on one of them. And really, it is about the COVID certificates. We have the debate coming up in the Chamber next week, which is actually one of the occasions that we'll get to actually debate legislation before it actually comes in and is enforced. So it's going to give the Assembly an opportunity to speak to that. But last Monday, in an answer in a question, the First Minister said that the COVID certificates were a policy that were not based on evidence, that there was no equality impact assessment completed, no human rights or legal opinion sought. And I think I hear much to the contrary. I'm a supporter of the COVID certificates, and I think it would be, regardless of the amount, can we just clear up, almost even in a yes-no scenario, Minister, is there scientific and medical evidence that COVID certificates will help?
Yes, the evidence, and I think you heard that from CMO and CSA yesterday in regards to reducing who is in a venue as well as the chair said, and I think it's important that it's not about getting that proof of, it's not just about vaccination, it's the negative lateral flow or the negative PCR in regards to the number of days previous as well. So I am aware that there are basically anti-vaxxers who are trying to latch on to this to try to prove their point in regards to anywhere else. The scientific evidence, as we said, about the reduction of spread for those who have been vaccinated or those who have previously been infected in recent days or who are currently negative. There's a reduction in spread. There's also, for those who are vaccinated, a less chance of serious infection should they become infected or go on to serious disease. So not the yes/no answer you wanted, Colin, but as brief as I could be in that.
No, that's appreciated. I think it's certainly highlighting that there is evidence that as part of an approach it works. And also, I obviously you're a member of our executive and we aren't. But in terms of the process, certainly for things like the quality impact assessments and for other decisions, is it normal for the executive, correct me if I'm wrong, to make the decision of what they're going to do, and then you go off and provide all of that their evidence that comes back in the statutory regulation, rather than having all of that evidence to be presented to the executive to make the decision? In other words, what the process that was followed for the COVID certificates through the executive was similar to all of the other regulations that were brought right throughout the whole COVID process?
There was nothing different in this approach. It was the same standard approach, but the quality impact assessment is available on the department's website in regards to where it sits along with the publication of the regulations. So that is done, it is there, it has now been completed, it is now available.
Okay, thanks very much, Minister. Thank you, Chair.
Thank you, and thank you for your brevity, Colin. And going then to Deputy Chair Pam Cameron. Go ahead, Pam, please.
Thank you, Chair. Thank you, Minister, and your officials for your attendance at committee today. And we don't underestimate the severe pressures that the health service is under. And I want to reiterate those very positive messages of taking up those vaccines and boosters and taking all the sensible precautions that we could all take. That personal responsibility is really important. Minister, I have a few questions here. I'll try to ask them very quickly. And then again, if we run out of time, maybe you could follow up in writing for any answers that you're not able to give me today. And the first one is, Carol touched upon the neurology inquiry report, and I wanted to ask if you will commit today to publishing that as soon as you physically receive it, and that there will be no delay in that publication. My next question is in around the £23 million package for domiciliary care, which I absolutely welcome. But if you could tell us how will you manage this in the new financial year? Because obviously, dom care workers need to be appreciated. They need to be paid properly. And we need to recruit and retain the people that are doing that fantastic work in order to ensure that those that can leave hospital can get to their own homes with that help that is required. But you can't roll back on their pay come the financial new year. You can't switch that off. So how will you manage that? Another question I have is I think a very critical one, and that's in terms of community pharmacy and the recent developments where the medicines adherence service is very much at risk. And we know the impact that the misuse of medication or wrongly taking, maybe wrongly timed taking of medication, we know the impact that can have in terms of hospital admission. And obviously we can't afford to have people come into hospital because the medicines have not been correct or not been taken correctly. So what have you any update on that issue? And my final one to you will be around where are we in the process of the request from the Antrim Area Hospital, from Northern Trust, for the 48 additional beds, which they badly need to deal with ongoing pressures in the hospital because there are not enough physical beds in Antrim Area Hospital.
Okay, thanks, Pam. Look, in regards to the neurology report, as I answered Carl as well, I have to receive it, then it will be considered for a while in regards to should maximalisation be necessary, anybody named in the legal process. But as soon as it goes through all the processes that it needs to make sure it's legally has been legally assessed and appropriately assessed, I'll publish it, because it's in my interest to get it out there as much as it is anybody else's. So I want to see it done as quickly as is possible. In regards to
Minister, sorry to interrupt, Minister, but so Pam and I did meet with the inquiry panel, but are you saying that maximalisation is going to be done all over again? Surely that's being done now by the inquiry.
That's what I'm saying. I have to make sure that's been completed, and those people have been given the opportunity.
Yes, but he'll not forward it to you until that's completed, is my understanding.
Well, that's what. Yeah, that process has to be completed before I get it. So we'll make sure, as we say, everything legally has to be done before I commit to publishing it, in advance of any of that work actually being completed. In regards to the 23 million, Pam, you mentioned, and I'm aware your party leader made a statement on this, which was quite I suppose surprising in regards to where you're actually asking in continuation for the new financial year. As you'll know, I don't have a budget yet for the next year, so there is, everything that's there at this minute in time is up in the air in regards to that budget process. I hope we can get a budget out from the executive that can be consulted upon and can then be agreed with the Assembly, that allows us to go through a 3-year commitment to health, but also the priorities that we need. In regards to the 23 million being non-recurrent, it's because I'm in a single year budget, but I have the money to be able to do that between now and this financial year. And it won't be about rolling back on people's pay rates either, because we're giving them the money, as Marcus said, through trusts to the providers so that they can manage it in that regards. Come the 1st of April, there'll be a new living wage, minimum working wage, which we should see reflected through the monies that we're actually putting out as well. So it is about the continuation of support. And again, our consultation on the review of adult social care should also pick up on a lot of that work. Lot of that work as well. In regards to community pharmacy, disappointed as to where we currently are. I hope it's not the end position. I know you're the chair of the APG on community pharmacy, so in regards to the specifics, there is an ongoing conversation in regards to the next 3-year service delivery plan, which is going well. That 3-year commissioning plan has been built on, again, like the continuation of domiciliary care, subject to funding. But we hope that's delivered. That plan actually includes a comprehensive adherence service, and that has been delivered and developed in collaboration with CPNI, something that we've been doing very, very effectively, and I think has worked very well over the last 2 years specifically. So look, disappointed that community pharmacy owners actually refused an interim offer of £5 million in regards to supporting them through the next 4 months, which would have allowed the adherence support to be provided for new patients. And again, not looking for silver linings in this, but I think community pharmacy have indicated that it's just for new patients. So anybody that's already receiving those blister packs, I think, as they're more commonly known, will continue to do that. So there was £5 million offered for the next 4 months to support additional works, but that bit as well in regards to community pharmacy. In regards to the 2 beds, I do know that Jennifer Walsh, the chief executive of the Northern Trust, and some of their own colleagues and CPD colleagues met about 2 weeks ago in regards to the concerns, that it's a modular building and the lack of single rooms that are currently in the current proposal. There's a meeting, I believe, has either just happened within the last day or was due to happen yesterday. In regards to those, I don't have an exact update to date. I don't know if there's anybody from the officials that are with me has a specific update on that. If not, I'll come back and write in detail, Pam.
Yeah, very briefly, please.
Yeah, thank you, Minister. If you could come back and writing on that would be good. I think the meeting happened at 5 o'clock yesterday. It's my understanding, because I was actually speaking to the trust at 4. In terms of that, the medicines adherence service, I just wanted to say, Minister, yes, I am chair of that all-party group on community pharmacy, but we have to remember that community pharmacy has been on absolute front line of this pandemic. You know, when GP access changed overnight and moved to phone first, the pharmacies were swamped. We all saw the pictures. We were all there in the queues or helping people to get their medications and supplies. And community pharmacy is under incredible pressure. And you know how well they are operating in terms of the rollout of the vaccination as well. And they have serious workforce pressures as well. So I think I would welcome your continued commitment to actually work with community pharmacy to make the improvements that are necessary, given that community pharmacy is going to be completely vital in terms of transformation of health service, and I think we need to embrace every avenue of help that we can in that. But thank you for your responses, and look forward to further and written response as well.
No, just chair briefly, and that, just to be clear, negotiations over funding have just begun actually with the department, and we remain committed to working with community pharmacy. For, as you indicate, we've had a great working relationship. I think a real partnership over the past year. So I was disappointed that they did initially refuse that interim payment of £5 million, which is roughly £10,000 per pharmacy, and that was to cover them for that additional adherence support work and a few other pieces over the next 4 months, until we actually get the fully commissioned service up and running on.
Have to rush you along, Minister. Yeah. Okay, thank you. Thank you, Minister. And Alan, and then with Alan, and then Jerry, and then Orlia. So go ahead, Alan, please.
Thank you, Chairman. Minister, obviously COVID is still going to play a major part in how the health service is going to cope with the winter pressures. What is your message to the Northern Ireland public in response to recent comments from senior politicians who seem to have become self-taught experts in epidemiology that this new variant is going to be a mild condition, as well as them taking a very public position on the requirement to wear face masks? Are these interventions dangerous in regards to public health messaging, and do they have a degree of potential to impact on your winter pressure plans? Thank you.
Thanks, Alan. Look, I've always said that a single message coming out of the executive, coming from this health committee, coming from the assembly to the general population was the one that was heard strongest. So any deviation from that central message, knowing what we need to do, knowing what we know that actually works, is one that I've always supported, of one that I've always asked for. Going back to Deborah's point, the importance of hands, face, and space in regards to washing your hands regularly, wearing face coverings, social distancing where applicable, taking up their vaccine, is something that we should always be doing. We retained the wearing of face coverings in Northern Ireland, where other parts of the United Kingdom moved away from them. Now they're now moving back to there. So I think we took the responsible decision. It's a decision that was actually supported by the entirety of the executive in regards to do that. So we'd no differential of messaging from here in regards to that. But it is disappointing when you get it from elsewhere, because there are those who take comfort in hearing that miscommunication or undermining of a message and use that as the signal that they're doing right. In regards to the severity of Omicron and this new variant, I'll take direction and advice from senior health officials. Should that be from the World Health Organization? Should it be from my own officials? Should it be from SAGE, or should it be from MHRA or JCVI in regards to how the procedures and the things and the vaccines that we have in place actually work in regards to that, rather than some other politicians who who have different sources of guidance and advice than I do. But I listen to the ones that have proved effective for us over the last 20 months.
Thank you.
Thank you. Thank you, Alan. And going then to Jerry. Go ahead, Jerry. So I'll just try Jerry once again. Then if I don't pick him up, I'll go to Arlena.
Sorry, Chair.
Yeah, go ahead, Jerry.
Yeah, thanks, Chair. Thank you, Chair. Thanks, Minister and panel. Minister, you mentioned staff are exhausted. Indeed they are. Every time I talk to them, they tell me physically they are, but they're also frankly exhausted and fed up with insulting pay offers once again. And obviously yourself with executive support are imposing a 3% pay offer, which I've said before. I'll say it again, it's insulting. It's below what they're worth. It's below inflation and below the rising cost of fuel and everything else. As it falls way short of what these people deserve. They kept us society going through a pandemic. They saved people's lives, looked after loved ones, and they were with people in their darkest hour in many cases. So I really want to ask, based on that, how does the Minister expect to keep our health workers working in the health service when they feel undervalued? And several unions are balloting for strike action or possible strike action based on this pay offer. What's the Minister's message to those unions, those workers, and what's his assessment of their rightful stand they're taking against this offer?
Thanks, Jerry. We lost a wee piece of your sound there, but I think probably the Minister got enough to get the gist of it, I think.
Jerry, in regards, come back to the 3%, that was what was agreed by the Independent Financial Awards Review Body, where we take our direction from, as does England and Wales. When the Department of Finance approved the Agenda for Change pay remit, I moved as quickly as I could to get it into people's pay packets, because I wasn't going to deny it from them in regards to the 3% that I'd actually got from a monitoring round bid as well. So I wanted to get that into people's packets. So that's 3% consolidated pay increase on all AFC pay points, and that will be backdated to the 1st of April. But addition to the pay in regards to working with our trade union side, I understand where they're coming from, on a UK basis. You asked me what my message. I would ask them not to go on industrial action, because I don't think our health service will stand any reduction in the workforce or the workforce that they're there. And I'd appeal to them, and I'll talk to them, and I'll work with them in regards to that. In regards to a number of other measures that were also put forward to our trade union side, along with the 3%, I did indicated again, I previously made an allocation of 15 million to our charitable funds across our trusts, and that funding has been specifically earmarked to support staff welfare, and I've asked trusts to engage with their trade union colleagues to agree locally how that earmarked funding can be used in each trust. I've also proposed and approved to extend the scheme to buy back unused annual leave that was actually introduced last year for all Northern Ireland HSC staff, again in conjunction and conversation with our trade union side. But as you're aware, the department faces a very constrained financial position within the current year. But to recognise the hard work and the dedication of our AFC staff, and subject to the department's wider budget positioning these, and I'm willing, and I have discussed with trade union side, to prioritise a bid as part of January modelling for additional resource for an additional non-consolidated award. But again, that'll need approval from the Executive and Department of Finance. So what that looks like, how it can be formatted, where it will be, to what level, and to what grades haven't been finalised yet. But again, we are having a joint meeting with trade union side and employers to look at key issues of pay and retention later this month, and then a wider joint summit towards the middle of, or the start of next year as well, just in regards to what we need to do. So again, conversations are still ongoing with our trade union side. I don't want to see them go to industrial action. It's not something I would ask them to do, and I'll keep talking and working with them to make sure we don't get to that point.
Thanks, Minister. I think obviously workers are, in my assessment of it, are being pushed out to take action, because there's no strong message, frankly, coming from the executive to say these workers deserve what they're calling for. I know you always say that they deserve more than they get, but I think, frankly, we need to see action around that, and the executive has failed to act on that, and health workers are feeling that they're not being prioritised again. But I have to move on just quickly because time is tight, obviously. Recent reports, Minister, of staff leaving the Belfast Trust. Do you or any of your panel colleagues have figures about how many have left the Trust in the last 2, 3 or 4 years? And also, finally, I've raised this in a written question to yourself before, Minister, about the right to work for asylum seekers, people who live here, who've lived here for years, because of immigration policies, frankly racist immigration policies. They can't work. And my understanding is there could be at least, and I emphasize at least, 100 health workers brought into our health system if asylum seekers, refugees and people with unsecure immigration status were allowed to work. So has there been any further pressure on the Home Office or other ministers in Westminster to lift that ban and to allow these people to work in our health service? Thanks.
Brief responses, please, or further follow-on information on that, Minister, depending which is possible.
I think in the last point, Jerry, we did meet the I'm trying to think, it's the migration advisory group to Westminster a number of weeks ago. That was specifically in regards to not migrant, more migrant workers rather than the group you're referring to. There has been no specific engagement that I've been involved in, but as you say, if you have a written response in or a written question, then we'll get back to you in regards to that. In regards to those who have left the Belfast Trust, I'm not aware of specific figures. I don't have that to date, but I am aware that there has been engagement specifically between unions and the Belfast Trust in regards to the last number of weeks. I think the letter that was actually carried in one of our local papers was actually written in October, so there has been ongoing engagement between trade union side and the Trust. And I met a number of the trade union leaders actually within the Belfast Trust a couple of weeks ago at a site visit I was at, and had a discussion with them at that point. So there is work ongoing, but as for specific numbers, we'll get back to you in regards to that as well.
Thank you.
Okay, thank you, Jerry. And then going to Orlia Flynn. Orlia, go ahead, please.
Yep, okay. So thanks very much to the Minister and the panel for coming along today and for your briefings. 3 questions. My first question is, after we met with the Royal College of Surgeons last week, one of the issues that they had highlighted was around the need for more protected beds. And I know obviously there's an element of, the workforce issues that we're having, and that might be difficult to do. But my first question is, Minister, if there are any plans that the department are looking at to try and maybe increase those number of protected beds in even the short to medium term. My second question is just to bring it back to the GP issue again. And again, when we heard from the Royal College of GPs, I think it was last week or the week before, I had asked them a direct question that in their opinion, did they feel that their telephone systems, the telephone triage, phone first system, that would have the capacity to cope throughout the winter? And their answer was no. So I find that really worrying. And I'm just wondering, with obviously that stark warning and the pressures that GPs are under, is there again anything that the department can be doing, over the next couple of weeks and months just to ensure that those telephone systems, don't collapse? And I'm just wondering if you have any sort of processes in place even to monitor some of the surgeries that might be struggling more than others, so you don't come to that crisis point where the telephone systems just basically aren't able to cope. And then my third and final question is around, we know the impacts that the redeployments within the health service are having on workforce, and Colin had mentioned earlier in his remarks around the example of Musgrave Park Hospital, where they've only 14 nurses out of 100 at the moment. So it's really around, Minister, if you can give any certainty that further redeployments, further scaling down of surgeries or services won't be required. And I know that's a really difficult question to ask, but I'm actually asking it to allow you the opportunity to send a message to the public that, alert them as to the dangers of genuinely the pressures that the health system is under. So it's trying to get that message across that this isn't even just about COVID. We know there is, COVID still with us. There's people still being hospitalised, but it's actually the impact that it is having right across the whole system in terms of surgery, services and workforce. So thanks very much.
Thanks, Shirley. Look, I'll pick up on your last point because, and thanks for giving the others and thanks for highlighting that point. How we prevent the having to scale back, having to step back or having to redeploy is having fewer COVID patients in our hospital and having to take those additional pressures. And I think what we see, the pressure really comes across the system when we have to redeploy to increase our ICU beds. As of yesterday, we were running, 92 ICU beds across our system. Now that's us working at a surge level 2, which means we're actually using more ICU beds than we have centrally commissioned or centrally funded. So we have to take staff from elsewhere to make sure those ICU beds are there to utilise and support the staff we are. How we could reduce the number of people in those ICU beds if with more of them vaccinated, that they wouldn't finish up not just in hospital but also needing that intensive care. So we've out of our 92 ICU beds, 30 of them have COVID patients in them. And, so that shows you, if 1/3 of our ICU beds are taken up by COVID patients, 50 of them by patients who have come through serious surgery that need that additional support at an ICU level as well. So, the capacity of increased surgery, because we have ICU beds there should we need them, if we weren't supporting COVID patients, the ability to redeploy staff to back to where they want to be, to back to where I want them to be, to back to where their surgeons want them to be, to back to where the patients want to be. So don't underestimate, the fact that COVID still has on the entirety of our system. So we alleviate the pressures on our system by having fewer COVID patients. And it's still, so it is still playing a part. We face our normal winter pressures. The health service across Northern Ireland has always faced winter pressures, but when we've compounded the pressure of COVID on top of that, is taken away from what we want to do. In regards to protected beds, I'll either look to Alistair or Peter, because that was one of the parts of our planning over, especially coming into this surge. And again, it was working through and working with the Royal College, with our nurses and with our trusts, like Alistair said, in regards to the city, to make sure those beds were there as well. So maybe Alistair could touch on that one. Yeah. And GPs in regards to the telephony, and again, it always comes back to that challenging point. And I think it was Carl touched on it, different approaches from GPs. It's because they all work as those independent contractors looking after their own premises. So we are looking at an investment into their telephone systems, and Garrod will maybe pick up on that. But I've also asked Dan West, as our Chief Digital Information Officer, to look at a wider piece that will take actually sustained investment into that entire system, so we could upgrade it, modernise it, and actually look to where we are. Personal example, myself and my wife are in 2 different GP surgeries. I order a repeat prescription by leaving a telephone message. She goes online. So, and that's that difference of approach. If we can get that standardised to make it as seamless as possible for the GP to improve their service, but also then in fact impacts the delivery and the service that the patients are getting as well. So maybe just first to Alistair and then Garrod, Chair, if you're content.
Yeah, thanks, briefly, please.
Thank you, Chair. Yeah, I will be very brief, and we'll probably go into this more, I assume, in a future session on elective services, because it is a big issue. The separation of unscheduled and elective is a key component of the elective care framework. I think it was mentioned earlier about our reliance on the independent sector, and part of that is because those staff just work on elective and can't be redeployed. That's partly why we're landing them. Those are completely green sites which can reliably and continue to provide elective surgery through any surge. In our own system, because of the capacity issues, there's always the caveat that if the unscheduled pressures get too high, staff would need to be redeployed. Now, we've tried to mitigate that in places like Lagan Valley, which is very effectively working. on that model as a standalone site. There are plans now as well to move to open more capacity at OMA to do something similar, again for the region, targeting areas such as urology where there are particularly long waits. Now, those are both day case sites. Obviously, I mentioned Belfast City Hospital earlier as well for the complex surgery, but those are our plans currently. The future model is separation of urgent and elective care, definitely, but that does rely on us having the staff capacity, particularly nursing capacity, to be able to do that through surges. I noticed Paul had his hand up as well, so I'm not sure if he wants to come up, but I'll finish there, and I'm happy to pick up in more detail in a future session.
Yeah, so we'll check with Paul briefly and then Gearóid briefly. Paul?
No, I was just briefly going to mention a column that we have 17 protected beds in an ICU for elective care. So we've done that in this surge, which we hadn't done in previous times, which is also helping us to do some of those more complex surgeries, which I think has been very helpful.
Thank you. And Gearóid?
Thanks, Chair. Just very quickly, well, as Minister said, and I've already outlined, we are making significant investment in the telephony side over the winter to try and boost the capacity to use the system to its most effectiveness. There's work underway on really scoping work on what a more integrated solution might look like. Now, because GPs are all individual contractors, it's not as straightforward. You can't. It's not a centralised provided service currently, and so that's it. That is in the early stages, but there's potential there if that kind of progresses well, that GP practice could have increased capacity, but also would link in better to kind of secondary care and the kind of wider health service system. So, in potentially very good work to be done there, but it's early stages. In terms of the thing about practices in crisis, there is a crisis response team run by the federations but funded by the board. So they do actively go in and provide assistance to practices who are in trouble. Both administrative support and kind of really to develop plans to help get that practice back on its feet, more than providing additional. It's not parachuting in additional clinicians. It's more managerial and administrative support to try and get them back on their feet in a more sustainable basis. But I can provide more information on any of those topics as necessary.
Yeah, no, thanks very much for those answers. And Gearóid, just to say that that crisis response team was actually referenced by the Royal College of GPs in our session. So I think they were making a pitch to maybe even get some additional support via that route. But no, that's been
looked at and managed between the Federation and the board. So
brilliant. I appreciate all those answers. Thank you.
Thank you. I'm going to bring Pam there briefly back in. Just Pam, you were looking back in there for a brief point?
Yes, Chair, thank you. It's really around the confusion that I feel is coming out of my question around the neurology inquiry report. I don't understand from the Minister, the comments around the maximalisation process, because that we've been told is happening now, and that will be complete before the report actually goes to you, Minister. So really, I wanted to reinforce that request for commitment from you, that when you receive the report, which will be complete, and those processes will be complete, that you will then immediately publish rather than hold on to it for a length of time. That was really clarity that I was looking for.
No, and I think, sorry, Paul, and I was waiting, and apologies for the confusion. That's what I was saying, waiting until all those legal processes were completed before I would publish. When I receive it, I will take time myself to read it before I immediately publish, because that's what I would want to do before I publish it, because we have to comment on it and I have to consider as well. But I won't be sitting on it for any prolonged or any sustained length of time, because that's what an independent inquiry is for. That's why I moved it to that form as well. So look, I'll publish it as quick as is legally and as practically possible. And I don't intend holding it in any shape or form. So I hope that provides that reassurance.
Okay, thank you.
Welcome that. Thank you.
So a brief one from me, Minister, and then I'll just go back to yourself for a few closing remarks. But I recently have met with the student heroes campaign, and there's been a number of events, but they have done a significant amount of work, and I feel they have a significant insight into the difficulties that medical students across a number of health and social care students, let's put it that way more accurately. So nursing students, social workers, allied health professionals, they have a very, I thought, a very considered and well researched view of the difficulties that are facing those people, and given those students, given the fact that we're reliant on them, and somebody made the point, the Royal College of Surgeons made the point, for example, no training today, no surgeons tomorrow, and that applies across every grade and profession in health and social care. But one of the things was that they had flagged up to me that they have asked to meet with both the Minister for Economy and with yourself. And I said that as far as that went, the minister I would be speaking to would be yourself, and that I'd asked you, will you meet with them, Minister, to discuss their concerns?
Certainly, Chair, because I think one of the things, again, when I meet the Royal College of Surgeons and the BMA, they always bring the chair of their student body, or on a number of occasions they brought the chair of their student body to those meetings as well, in regards to the future of the service as well. So, yep, look, I've no problem in meeting them, Chair, in regards to that interaction, in regards, because if you say, difference in approach in regards to, our medical students are usually in placement at some time during their course, should that be in primary, secondary, or placement anywhere else. So that it's not just the fact that they're all theory. They actually come onto our front line and work side by side. And, we saw that actually in regards to where they were and the help they provided during the first and second waves, where they were actually keeping their service and supporting it as well. So.
Okay, well, listen, thank you for that, Minister, and thank you to your team. And it was a very knowledgeable panel, and I suppose, as always, we'd have loved to have longer on the individuals and longer. I recognise that each and every one of you probably have a full session in your own right in terms of the expertise you bring to it. But I appreciate all of you coming to committee today, providing those answers, and committing to provide the additional information. I'll leave the last word with yourself, Minister, in terms of do you want to give a message in terms of what we can do as a health committee, and how at this current time we can support the predicament and the stresses that are out there in the system?
No, look, Chair. I think just in starting with your comments in regards to Peter Garrode, Alistair Paul, and Mark. Not often they get thanked in public, but I want to acknowledge the words that you pay. But I want to thank them as well, and their teams, because of the work that they keep going and actually do behind the scenes to make sure all this is deliverable, all this happens, and we keep our health service going as well. So, in regards to that acknowledgement, Chair, and look, if you want any of them back for a standalone session, I'm more than happy to make them available to you. In regards to that. But again, from that joint message, Chair, and I'm thankful, it was nearly touched on earlier on, can I just thank yourself, the Vice Chair, and all the members of this Health Committee for the continued consistent messaging that comes out from this committee, not just in support for those working in our health and social care system, because it is vital, it's crucial, but the fact we've been able to do that between ourselves as a department, me as Minister, and you as a committee, we've done that in partnership over these past 22 months. That's what people expect to see from us, and that's what they do see from us. But it is about that continual message. It's about the hands, face and space, but also the vaccination programme, doing what we know that works, and supporting our healthcare staff and our healthcare system by doing that. So come forward, get your vaccination when you're applicable. Should that still be those who are now convinced that the first dose vaccine is for them, come forward and get it. Get your flu vaccine. If you still have to get your second, come and get it. If you have to come and get your booster when it's applicable, come and get that as well, Chair. So it's just, and again, thank you for the support that you have given and the continued partnership working that we have.
Okay, listen, thank you all, and please take care, and wish you all the best in your roles in the time ahead. We're still in difficult waters, so all the best for now. Thank you. Okay, members, I think we have I think a fair amount of information there to be forwarded on, and hopefully that will be something we can consider. But any other brief points? I don't think there's much outstanding. Keith will have probably captured all of the relevant information. So, okay, members, I'm going to move on then. We have a lot in front of us today again, so I'll move on back to the original starting point of our meeting, which would have been moving on to Chair's business. So just to flag up there, as has been touched upon, that myself and the Deputy Chair met with the Chair of the Independent Neurology Inquiry last Thursday afternoon. A short note of that meeting was shared with members at the start of this week. So members have the note of that meeting. The other thing I wanted to say briefly was just I was aware of an issue that's been raised around Alcan, a young child requiring stem cell donation, and just I think to take the opportunity to flag up the importance of blood donation at this time, and plasma, and blood donation is fairly well known about, plasma's less so, and I think stem cell donation less so. But I just want to flag up at this particular time that people who are willing to donate blood or plasma or stem cells, that is something that is obviously hugely being sought after. So I'm going to move on then to draft minutes, which are at tab 3.1. Are members content with the minutes there? Yeah, members content, thank you. And I also refer members to the minutes of the meeting of the 30th of November, which are tab 3.2 of table papers. Are members content with those minutes? Yeah, thank you. And then in terms of matters arising, members agreed last week at our meeting last week to request an extension of the committee stage of the hospital parking charges. Are members content with the draft motion to extend committee stage to 28th of February, which is a tab 4.1 of the pack? Are members content?
Content.
Yep. Okay, members, before I go to item 6 there on the ambulance service, I'm going to take a short break. So maybe I think if we could come back at 11 o'clock, we'll take a 9-minute break there and we'll revert to the ambulance service briefing at 11 o'clock. Thank you.
Hey, Chair, that's us back on. I can't see your picture at the minute.
Okay, thank you. Is that okay now, Clerk?
Yep, that's us.
Yep. Okay, thank you, members. So we'll resume then our meeting with item 6, which is a briefing from the Ambulance Service Trust on winter pressures as part of our consideration around a range of issues on winter pressures. I refer you there, members, to papers at tab 6 of the pack, which include a copy of the Trust's Winter Service Delivery Plan at tab 6.1. I'd now like to welcome via Starleaf Mr. Michael Bloomfield, who's Chief Executive of the Trust. Can you hear us okay there, Michael?
Sorry, Chair, it's looking like we're having a problem with getting him online at the minute. He's been on a couple of times and then it's went off again. I'm just wondering, is it worth heading on to correspondence and we'll try and get the officials back on?
Yeah, okay. So, members, we will move then on to correspondence. So, can I draw members' attention to a number of items there within correspondence? First of all, item 11.6 is from the Eating Disorder Forum in relation to the recording of an eating disorder on a death certificate. Do members have any comments in relation to that item? I'm not seeing Deborah. Go ahead. I think I see Cara. Yeah, Deborah, and so I'll go Deborah and then Paula.
Yeah, Chair, I suppose my comment just in relation to that would be I would just have concerns because eating disorders is a really, there's an awful lot of people suffering with eating disorders, and I would be worried that, deaths aren't being properly recorded and reported, and then that impacts upon the services that we maybe, through the numbers that we can maybe then get implemented for people to provide support for them. So I just want to make sure, maybe if we write off, just to ensure that we are getting the right services in place with the numbers of people that are presenting to the current services, and, to make sure that deaths do be reported properly, so that if we need to make changes, and I think we do need to make changes to the eating disorder services that are in place for people at the moment. So I would just have concerns if they're not being reported properly, we're not getting the right services in place.
Yeah, and I would share that concern, I have to say, and I suppose we also need to be cognizant of sensitivities of families and what's published on the published, but I think it's vital that we get the data, and I think it ties into some of the work that I know Arlene and myself have been involved in around the whole idea of psychological autopsies, and I think it's in keeping with that, whereby that there is a very clear data trail as to what is happening out there. I think it's an area that I've become increasingly aware of actually some of the deficiencies we have around good health data here. I make the point again, it all flows through our hands in the system at some point in time, but we seem to be particularly poor at firstly capturing it and then acting upon it. So I think anything that improves that. So I think asking for further clarity on that would be a good idea. I want to check, I'd seen Paula's hand, I do see a hand from Carol as well. I'll just check, Paula, were you looking in on this or something else?
Yes, Chair. Chair, I was just to say, I'd obviously also received a letter and I forwarded it to the Department of Justice as well, because there's a crossover there in terms of the coroner's role in this regard. So as soon as I receive a response, I will forward it to Health Committee members. Just to update on that.
Thank you. And Carol, were you looking in on this item?
No, Chair. No, neurology, Chair.
Okay, we'll come to that. It's flagged here as well. So, okay, members. So we'll write and seek further information on that. Item 11.9 then is from the medical. Sorry, go ahead.
Sorry, Chair. Sorry, I meant to add just if we can check if we're doing things differently to counterparts in England, Scotland, Wales and the Republic of Ireland as well. Just I think it's important to see how we're comparing. Sorry, Chair.
Okay, thank you. So you content you have the detail there, Clerk, for that? Yeah, okay, thank you. Thanks, Deborah. Item 11.9 then is from the Medical Practitioners Tribunal Service, and item 11.13 is from the Professional Standards Authority, both in relation to the decision to approve Michael Watt's application for voluntary erasure from the medical register. The correspondence from the PSA advises that it has considered this case and it lodged an appeal last Friday in the Belfast High Court on the decision to allow voluntary erasure. And I know that we as a committee have written to the PSA in relation to this matter, so I think that is a welcome step, I have to say. At tab 11.24 in the table pack is a response from the PSNI in relation to the committee's query on whether it was undertaking any investigations relating to the conduct and work of Michael Watt. The response advises that the PSNI are still undertaking work on the issue and has liaised with a number of external investigative bodies and with some former patients. So do members have any comments they wish to make in relation to this item? Carol, you had indicated?
Yes, Chair. So I understand that given the fact that there's legal processes, I'll just be mindful of what I say, but I do welcome the committee's certainly they're initiating the correspondence to the PSA and PSNI and others on this issue. Chair, one thing I do want to raise is that given the fact that the maximalisation process is still underway, and I'm glad that the Minister has clarified that, so he'll get the report from what we heard this morning. He'll get the report after the maximalisation process has happened. But can we ensure, so I would ask that we write both to the public inquiry team but also to the Minister, can we ensure that the families impacted who have fed into the inquiry are met with, spoken to before any publication happens, because this is going to be very, very sensitive and very traumatic stuff. And I don't think it'll do any harm, to be honest, in asking that.
No harm in writing. I do think my understanding is that would be the case, but I think it's important to put it on the record as well. Would members be content that we write to ensure that families are told before anything goes public? Yeah. Content. Any other comment, members, in relation to those two items on neurology? No. Okay. So thank you then. Moving on to item 11.16, which is further correspondence from an individual in relation to the Valley Nursing Home in Clogher. Just to let members know that I have spoken to this individual. He is from my own constituency, and I have spoke to him in the past around issues around this, and that I'm going to take that forward as an MLA separately, and I've discussed that with him. So if members are content, I'll take that forward as an MLA. Yeah. Have members any comments they wish to make in relation to any other items of the correspondence today? Or Leah?
Yeah, Chair, it was just to highlight the members' correspondence 11.11. It was on the petition, the public petition that I brought to the House 2 weeks ago from a bereaved family in West Belfast. And it's around calling for improved addiction, rehab and crisis services. So it's just to encourage members maybe to get a wee look and to try and share it or sign up to it if they haven't done so already. And it's obviously just predicated on the seriousness of the issue. We know that drug-related deaths are having a massive impact right across the 6 counties. And there has been a huge increase in these types of death, so it's just to sort of bring that to the attention of the other members, and anything that I'm involved in with the families coming up, I'll let the Health Committee know if they want to show their support. Thank you.
Okay, thank you. And just at that point, so that's the main correspondence. So are members therefore otherwise content with the actions on the correspondence list? Okay, thank you. And before I go to table, there are 2 items in table, but before I go to those, I'll check with the clerk if we have the ambulance trust online, and if we do, I'll go to that briefing and we'll come back to the table correspondence. So, clerk, do we have the ambulance service online?
I see Michael Bloomfield's on by phone there, Chair. So yeah, we'd be able to go to that briefing now.
Okay, so we will. We'll go then. So I'm going to first of all check, Michael, are you able to hear us?
Sorry, Chair, it looks as though he's left the call again. Must be technical issues on their side. If we give it a wee second and see if he comes back in.
Yeah, we'll give it a sec. So if we don't get anything within the next minute or two, Keith, I'll go back to the correspondence and give it a wee space. But for now, we'll hang on, because I know that broadcasting can normally deal with these issues better when we're still online.
Hi, Michael. Are you able to hear us okay? No, Chair, there seems to be an issue with the connection there.
Okay, so we'll go back to these other items of correspondence. That'll give them another few moments. So I'm going then, members, to tabled items of correspondence within tabled papers. At tab 11.17, there are copies of the common frameworks for blood safety and quality and organs, tissues and cells. A briefing on these frameworks will need to be scheduled at an early stage. So do members have any comments they wish to make in relation to that item? No, content that we look at scheduling a briefing. Okay, thank you. At tabs 11.20 and 11.21 are responses from the department to issues raised in written submissions and to issues raised at second stage. Are members content to note those at present? Yeah, members content, thank you. Okay, I will go on then, but without any indication back from the clerk, I'll go on ahead to forward work programme, and I refer members to the forward work programme at tab 12.1 of the tabled pack.
Sorry, Chair.
Yes, go ahead.
The tabled papers correspondence, there's an item in there from the Royal College of GPs, and it's touching on some of the themes that we were speaking about with the Minister and the panel in the last session. And there is a section in it around that crisis response team that the Health and Social Care Board can support GPs in rolling out. So I was just wondering, I should have maybe said during the last session, if we could maybe follow up in writing to the board, just to see if they can sort of take that forward with the GPs, because as I said in my earlier remarks, I'm just conscious that if they're already struggling to cope coming into the winter period here, it's just to see how we can help support them in that crisis response team.
Yep, members content with that? Yep, thank you.
Chair.
So, yeah, go ahead, Pam.
Yeah, it was just on the back of Orlea's query there with that letter as well. And could we also write to, I think it was the Health and Social Care Board that were undertaking the survey in terms of the telephony, to see, obviously, that there was 1.7 million allocated to GPs to improve their technology. But we're also aware that there's a survey that's ongoing or just started, but I think we need to know where that is. There's not much point in allocating money if actually GPs are not in a situation where they can actually do something with that money in terms of upgrading or getting new contracts in place, which will hopefully help with the GP access issue in terms of how you actually get through to the surgeries in the first place. So I just think if we could get an update from I think it was the board that was undertaking that survey, that we could find out what's happening with that and what the timescales are for having that completed.
Yep, members content. Yep, thank you, Pam. Okay, checking back with you, Clerk, before I go back to forward work programme. Have we any progress with ambulance?
None yet, Chair. We're working, trying to get in touch with them, and we're also seeing about the officials from the Department of COVID Cert to see if we can bring them forward. So we might need to pause for a few minutes just to allow us to set the next one up.
Okay. Well, I'll deal with the forward work programme then. So I'll refer members to the forward work programme, which is at tab 12.1 of the table pack. Are members content to note? Yep, members content to note. I'll also take any other business at this point, just to allow members to the committee staff to work on the connections there. Do members have any other business that they wish to raise today? No. Okay. So listen, I'll go back to the clerk then. I'll check on progress with either of the sections.
Sure.
Yes,
Sorry, it's just that in our packs we received the reports from the trusts in relation to the winter pressures and indeed COVID. I remember some time ago we had the chief executives of the trusts in. It might be a good idea, if possible, to try and schedule that in as well at some stage, just to talk about their plans to retain and recruit staff and deal with the winter pressures and indeed the hospital or the surgical waiting list as well.
Yeah, well, I am conscious that we are fairly packed out over the next couple of weeks in December, but I think we can certainly put it on there for consideration at the earliest possible point, I suppose, or at an early point. But so I'll go back. So clerk has that noted there, and we can take a look at how that might be accommodated. And I will check then again with you, clerk, in relation to either of the proposed sessions.
Sorry, Michael Bloomfield's coming in and out of the call there just every couple of minutes, so there seems to be a problem with them joining. So if we could have a couple of minutes just to see if we could bring forward the other briefing, and then we can work on trying to get the ambulance service sorted. And if not, we'll maybe just need to reschedule them for maybe next Tuesday or next Thursday. So we might.
Okay, well, we'll take a 7-minute break there just to bring us up to 11:25 and resume at 11:25, and hopefully then that will give you time, clerk, to have the officials on the regs.
No
okay,
problem,
members, thank you. We'll go back at 11:25. Thank you.
Okay, Chair, that's us back on and ready, and we have Elaine and Peter on the call. Sorry, Colm, you're muted.
Okay, thanks for that, Keith. Okay, so we will. So, members, we're resuming then at item 7, which is SR 2021/315, the Health Protection Coronavirus Restrictions Regulations NA 2021, Amendment number 19, Regulations NA 2021. I refer members to the papers at tab 7 of the pack. Department officials are here today and are present to brief the committee on the provisions of the SR. So I would now like to welcome via Starleaf Elaine Colgan, who is the Head of Health Protection. Good morning, Elaine. Can you hear me okay?
Good morning, Chair, and yes, I can hear you okay.
Thank you. And we're also being joined by Peter Looney, and Peter works within the Executive COVID-19 Task Force. Can you hear us okay, Peter?
Yes, I can, Chair. Thank you.
Okay. Thank you. So, Elaine, I'll go back to yourself then for your presentation, then we'll go to members. Thank you.
Okay, thank you. Thank you for the invitation to attend today, and as the committee is aware, we're just considering the one amendment today, which was the result of an executive decision on the 17th of November, and that was amendment number 19 to the restriction regulations made on Monday past the 29th of November and came into operation on the same day. Members will be aware of the main provisions of this amendment, and they have been well rehearsed and discussed already. So what I would like to do, with your permission, Chair, is to outline rather than outline the provisions themselves, just to brief members on a couple of issues around the process that took place regarding them. So firstly, I would like to outline how we changed from the original plan to combine a consolidation of the existing regulations with the new COVID certification requirements. I'm conscious that members were sent an SL1 that we submitted to them, outlining the proposals to make a consolidated set of regulations with the certification provisions not initially commenced. Those would then be commenced at a later point if and when they were required. Unfortunately, the decision to introduce certification came earlier than we had expected and anticipated. In discussions with the PSNI, they indicated concern that if we were to do a consolidation at that point, that there wouldn't be sufficient time to redraft and reprint their fixed penalty notices, and that would actually put them in a position where they weren't able to issue fixed penalty notices for any of the restrictions, not just the new certification provisions. So obviously, coming up to Christmas and in the time that we are, that wasn't feasible. And in light of some of the time pressures and associated procedures, which I'll come to in a second, it was decided that it would be better to pause the consolidation and focus on introducing certification as an amendment. So that's where we ended up. Just on the consolidation, we are still working on a consolidation, and we're working with PSNI to coordinate the timing, and that will be done at some point within the next 1 to 2 months when we get a bit of a stable period to do it in. The introduction of status certification itself as a policy required some considerable additional work beyond the drafting of the regulations itself. And it was important that as much of this as possible took place before the regulations were made, because the reason for doing most of it is to highlight issues that might require either a change in direction or a change in approach in the regulations. So I just want to touch very briefly on a couple of those. The first is the full human rights impact assessment, and that was completed before the regulations were made. It's currently pending finalisation, and it's with the Northern Ireland Human Rights Commission for their initial comments. We do plan to publish this on our website within the next couple of days, and that will be available for the public. The second piece was the full statutory ICO Information Commissioner's Office notification and statutory data protection impact assessment. And this was submitted to the ICO for comment in advance of making the final regulations. It was a really helpful exercise, actually. It informed our guidance of the regulations and what needed to be included in that in terms of data protection. And it was really helpful that we had their engagement in advance of making around data protection and the use of personal data by others. And the final piece was an equality impact assessment screening exercise, which was carried out. This is already available on the website and was published with the amendment on Monday. And I'm pleased to say that no equality concerns, issues of concern were highlighted, and a full equality impact assessment was not required. And I would like to just finish with a brief mention of the grace period. The regulations were made and came into force on 5 p.m. on Monday, the 29th of November. COVID status certification is now currently a legal requirement for all of those events and premises to which it applies. However, to give the scheme time to bed in, the executive agreed there be a 14-day grace period, during which time fixed penalty notices would not be issued. The purpose of this period of time is to allow both the affected sectors and members of the public time to get used to the workings of the scheme and for issues to come to light within the operation of it that may need addressed. And I would just like to emphasise that the benefit of this to the citizen can only really happen when businesses are operating the scheme, because only then will it come to light if there is a difficulty with their evidence or perhaps their understanding of the requirements or their need to take an LFD test, for example. The grace period allows flexibility to businesses in the knowledge that fixed penalty notices won't be issued should a non-certified person be found on their premises. If the schemes aren't operated until after the grace period is over, benefit for the citizen is reduced, as they would have to be refused entry if they had not come prepared. So discussions took place at length over the best approach to the grace period and law in terms of making the regulations or laying them in draft for Assembly approval without using the emergency procedure. It was considered that the situation was such that there was an immediate need for COVID status certification to be a legal requirement from Monday the 29th of November and to be operated by the businesses captured. And this was the reason for the emergency procedure being used in this case. So Peter and I are both happy to address any questions that members might have.
Okay, well, thank you. But first of all, now I'm a bit confused. I have to say, you haven't briefed us on the regulations themselves, and we won't be making. Well, just let me finish. We won't be making a consideration on regs that we haven't been briefed on. Now, I do have indications from members, and I will take those members in for questions. I have some myself. But I will say that we will be requiring a briefing on the regulations themselves before we move to our formal consideration, Elaine. So just bear that in mind, please.
Well, if you want, Chair, I can do that now. I can go through what the regulations themselves. I have information here if you would like that now.
That's normally what we do. So I don't understand why we wouldn't be doing that.
No, that's fine. I just thought that given that it was already kind of known what was in them, that it would be helpful to outline those other things instead. But no, I'll go through this now. So the amendment that was done was, as I said, down to decisions on the 17th of November, following an increasing number of cases and hospitalisations causing severe pressure and operational challenges in hospitals. The executive decided to introduce those provisions effective from the 29th of November. So the amendment introduced the requirement for COVID status certification in certain events and premises through one of three methods: proof of full vaccination, proof of negative COVID-19 lateral flow rapid antigen test within the last 48 hours, or proof of recovery from a positive COVID-19 PCR test within the previous 30 to 180 days. And those are the three ways that you can gain entry into the relevant settings or events. The regulation allows a person to prove their certification in a number of ways. So the certification by vaccination can be proven in terms of paper or electronic form, showing that you have completed a course of doses of an authorised vaccine, with the final dose having been received at least 14 days before the relevant time. For the rapid antigen test, or the LFD test, the certification evidence is through the text or email that a person receives once they report the test through the NHS COVID-19 reporting system online. And this must be done within, or the test must be taken within 48 hours of the relevant time. For a positive PCR test, then the valid notification that you received for that test is able to be presented, the email or text, and that must have a date on it of the test taken no earlier than 30 days before the event and no more than 180 days before the event. The other accepted pieces of evidence are confirmation in writing of the person's participation, either their current or past participation, in a clinical trial for vaccination against coronavirus from the organiser of that trial. And the other piece of evidence is evidence provided through the Northern Ireland COVID certification process for medical exemption of a clinical reason for not being able to be vaccinated with any authorised vaccine, or an equivalent process in that person's place of residence if they're not resident in Northern Ireland. The regulations state the responsible person for implementing the regulations regarding premises includes the owner and the proprietor and the manager of that business or service of those premises. In relation to a relevant event, the person responsible for organising that event or the person responsible for the management of the premises at which the event is held, if no other person is responsible specifically for the event itself. There are a couple of exempted events, and they're specifically named in the regulations. So those are a funeral, a marriage ceremony, a civil partnership registration, or a reception or gathering, which relates to a funeral marriage ceremony. A drive-in event, a lawful picket, an illuminated trail or pathway, religious worship, and an outdoor public place event with no fixed entry points and where there's no payment or tickets. So I hope that's been helpful to members, and I think that covers the regulation briefing, but if I've missed anything, then please do say, and I'll do that now.
Okay, and I suppose that to me it's an important part of the process. You had mentioned, I think, in your remarks, confusion around business, and this is where some of that gets teased out, and I think that's a crucial part of it. So I'll have a few myself, and then I'll go across to members. Okay. So how does this rule impact staff working at licensed premises?
So staff are not required to have certification if they're working on the premises.
Okay, and why is that the case?
Well, it's sort of it's more to do. We don't want to interfere with the person's work. You know, they have to be there for work purposes. So at this point, we have exempted employees.
Okay, how will compliance be monitored? And we have touched upon monitoring over the last number of weeks. So how, in this case, will compliance be monitored, Elaine or Peter?
So compliance with all the regulations, we do liaise heavily with PSNI and get their feedback on compliance. We don't have anything specifically lined up for this. I don't know, Peter, if you have anything on the adherence side of the adherence group.
Yes, Chair, the plan is that the police will be out during the grace period, visiting licensed premises and using the first 3 E's of their strategy to encourage and make sure the businesses are prepared to implement COVID status certification. The enforcement side will be held off until the end of the grace period. And from I think it's 13th of December, then the ability for the police to issue fixed penalties, the police and other enforcement officers to issue fixed penalties or take prosecutions will come into effect. I think it is very much a case of trying to work in partnership with businesses to ensure that they are both ready and doing what is required of them. Enforcement obviously has to be the backstop. But
just a second, Peter. Just yep. let me. And I appreciate the information on enforcement, but I asked about monitoring. How will this be monitored?
The responsibility for monitoring uptake would sit with the enforcement agencies. So police and local government and to an extent HSE would be responsible for compliance in that area. The digital solution will give us some information about sort of numbers of certificates downloads, number of checks carried out. So we will be able to see that at a macro level. But it won't hold granular details, which will allow us to test that on a premises by premises basis.
Okay, and then finally, and from me, and then I'll go to members here. What advice has been given to business owners in relation to implementing the certification rule?
Well, Peter can update specifically on some of the stakeholder engagement that we've happened in the last couple of weeks, but certainly from our side, our guidance was published online on the same day the regulations were published on Monday. It was version 1. We had a second version updated yesterday with some more in-depth information on data protection, and it is an iterative process. So as issues are raised with us by businesses through Peter largely, we are updating that guidance and putting on more information. We also have a set of frequently asked questions on our website, which has been there from, I think, around the start of last week. So there is guidance from that perspective as well. So Peter, is there anything you want to say on stakeholder engagement?
Yes, we held a number of sessions with specific sectors. So we've had several meetings with hospitality, we've met with events, we have met with retail, and we have explored, we've outlined to them how the process operates, and we've explored to them areas of concern. That will be an ongoing process. We're meeting again with them later on today, just to get their feedback on the first few days of operation. We are, as Elaine said, using this period to capture their feedback, to refine the processes, to address any issues of confusion or lack of clarity, and we're responding to them as quickly as possible. That sector engagement is key, because obviously they are able to give us feedback from their members about what they see as the challenges, and that's allowing us to refine the process to make it more operable and more streamlined.
Okay, and actually there's one other final one from me. Is so the Minister had indicated some time ago that he wanted to bring this scheme in earlier. So was the work parked on it, or I'd have thought a lot of this work would have been ongoing across the summer period, looking towards moving into winter. So why is it taking till now to start doing? And it seems very dynamic. I have to say that there's still a lot of iterations going on and a lot of work going on. So can you explain why this wasn't done earlier, to have the scheme, ready to roll out in a kind of a more finalised fashion?
Yes. So I guess we were working on it. The technical team particularly were working on it from quite an early stage, and it's down to that's enabled the app to be available already. We were aiming for having this ready for sort of early mid-December, so that would have given us an extra week or two to work through the issues, and to get it much more clear in terms of what was needed in drafting terms. But we were, as I mentioned, doing it in parallel to consolidation, which is in itself quite a bit of work. So I think we were probably caught a little off guard in how quickly this was required, if I'm honest. And so that I think is really the crux of it. It's not that we weren't working on it, we were, and with another couple of weeks we probably would have been there quite stably and quite much better than we were on Monday, I suppose.
Okay, I'm going to go across to members then. So at this point in time, I have in front of me here Paula, Colin, Deborah, Jerry and Pam. So I'll start at the start there again with Paula. Go ahead, Paula, please.
Thank you, Chair. I have a couple of questions. The first one relates to Section 16E, and this is the areas or the locations that aren't included and have been excluded. And I'm wondering if you can give me a justification or an answer in relation to ports or airports and also places of worship. Thank you. First question.
Okay, so ports and airports. You might recall around this time last year, whenever the most severe restrictions came in last winter, we closed hospitality and we had very severe restrictions between Christmas and New Year. And at that point, the issue around ports and airports came up because you have people, they needed to be open for essential reasons for people traveling. There was nowhere really else they could use facilities. And it's the same here in the ports and airports, that they're traveling and there's reasons that might mean they're not necessarily have the evidence on them at the time. The travel period might be more than 48 hours, for example. If they're not vaccinated, it's hard to get a test. So that was the rationale for the first one. The places of worship is actually around the provision of any alcohol in the for communion. So that would allow for that to happen. It's not an operational issue, obviously. That's not going to be taken up, but it just for clarity to make sure that they weren't caught illegal, I suppose, technically.
No, appreciate that. Okay, I suppose I'm not sure whether you were watching earlier, and I mentioned to the Health Minister concerns for the elderly, not least those who attend church, in terms of not having smartphones and finding the whole stuff online. I just wanted to raise that with you as well, just to keep that under review. But I suppose the main second question is in relation to the availability of the lateral flow tests, and a lot of the correspondence we've had as MLAs has been very much on the certification app, and I think that the messaging's got lost a lot around the alternatives to that. I'm just wondering, are you going to do any campaigning social media or otherwise, in terms of notification where people can get these very readily? Thank you. That's it.
So yes, the elderly and sort of the vulnerable is something that we have in mind, and actually it's why we allow at the moment paper certification. So at the moment we haven't limited this to QR codes, which is what ideally we would do. But in order to get a paper QR code, the person needs to phone up and to apply for that and to go somewhere and prove their identity, and that can take a couple of weeks. So we have allowed for the vaccination cards that you get when you get your vaccination to be used in an interim period. We will continue to engage with the sectors as to how long that interim period needs to be, to make sure that those people aren't disadvantaged by the introduction of that, so that if they don't have a smartphone, they have had time and opportunity to get a paper version. The availability.
Elaine, just before you go on, I had a constituent in South Belfast, and they were advised, I think one was in Newton Ards and one was in North Belfast, or maybe even further, Newton Abbey. Like, it is a long way for people to travel, especially if they're carers, they can't leave, it's really very difficult. And I'm just wondering, is there an alternative, again, to actually physically taking the identification? But I suppose you have it under control. But I'm just raising a concern about the distance some people are travelling.
Okay, I can certainly take that back to the team and see if there's maybe more venues or something that could be looked into. So yeah, I'll take that one back. Availability of LFD tests. That's not an area I'm working on, but I'll certainly go back and see if there's any comms planned. At the moment, you can get them in leisure centres and pharmacies over the counter, but you can also go online to order them and just get them posted to your house. And if your workplace takes part in a workplace scheme, then they will also have them. So that they are generally widely available. But yes, I take the point, and I'll feed that back to colleagues about trying to get some more communications out there as to where people might get them.
Thank you, Chair.
If I could just note as well, Chair.
Yep.
Sorry, I was just going to note as well, Chair. I hope to meet the Commissioner for Older People tomorrow, and we'll hopefully be able to take up some of those points that Paula has made.
Thank you. I appreciate that, Peter.
Yeah, and just in support of that point, my understanding is that people from Derry would actually have to travel to Magherafelt, which not only raises problems individually, but it also seems counterintuitive that you would send such a large population into a smaller town. And there are cases of, and I've made this point before, there are places very poorly served by public transport. There are people who don't drive cars. There are people for lots of reasons would struggle. So I think that is a very, very useful point to pick up on. Brief one, Pam, are you looking at a brief one on the church issue there just before I go on?
Yes, Chair, thank you. I appreciate I'll come in later with my own questions, but it was just for some clarity around the church issue. Elaine, you'd said that the exemption is around churches because of the licence element of it, and I get that in terms of church services, but what about actual church events? And obviously at Christmas time you would tend to have lots of different church events, not necessarily church services, but are they so are churches completely exempt, or is it just the element of church services that may include communion wine or something like that?
Yes, it's just those elements of service at the moment, and that's sort of one of the issues why we are taking a phased approach, and licensed is only in first. Most of those other types of events in church premises wouldn't involve alcohol, so they don't need to be exempt, because churches obviously aren't necessarily serving alcohol during those. The wider issue that is one that we have to deal with in the next couple of weeks, to move to the non-licensed hospitality, is the issue around kind of community services and the provision of food and drink that might be free to the vulnerable for certain things, and providing tea and coffee, for example, at a parent and toddlers is one of those things. So that is something that's on our radar, and it's partly the reason that we have only introduced this for licensed at the moment.
Okay, so just for clarity, Chair, so churches are not exempt in totality for events. Okay, thank you.
Okay, thank you. Colin, go ahead, please.
Thank you, Chair, and thank you, Elaine and Peter, for the update. I was trying to read through the regulations. I'm struggling just with the language in it to try and find the issue of children. Obviously, children by and large shouldn't be in a bar, but it wouldn't be unusual for them maybe to be there during the daytime. And just some sort of landlords were sort of wondering what they would do in that instance, and if there's a particular age range and up that it relates to.
Yes, so if you're under 18, you don't need to prove certification, but there has been kind of confusion around this because there's a misunderstanding around the evidence, and we've been getting queries about what evidence a person who is under 18 needs to prove because they can't get certification, and they actually don't need to provide any evidence. The evidence only applies when certification kicks in. So if you're under 18, you don't need to do anything. You're not captured by these requirements.
Okay, and I suppose it builds into the point maybe just about, is the messaging something that's a responsibility of your side of the house, or do you pass that to somebody else? Because there is a lot of confusion out here, and I think just anything that we can do to ramp up the messaging. You referenced something on a website there, and I very quickly went on, and I don't know where I'm looking to find it, and it's like you would just want something where you're kind of almost Googling, hospitality restrictions and COVID certificate Northern Ireland. It'll bring you straight to it, but it just doesn't seem to do that at the minute. So where is that information and guidelines?
Peter, do you want to take the NI Direct bit, and I'll
Yes.
do the bit that's on our website. So what we have on our website is what is always there for the restrictions regulations. So we have guidance published for it explains what the regulations require, and that's on our website beside the restrictions regulations. So if you go in and go to COVID legislation from the homepage, that's where you find that. We also have FAQs, which I'm fairly sure there's a link, and I'll maybe check this when Peter's talking, but I think there's a link on the homepage that actually says FAQs for COVID certification. So I'll double check that when Peter's talking now.
Yes, Chair Colin, there is information on NI Direct which tells citizens what they can expect in relation to COVID passports. It's been on there since the scheme was operated on a voluntary basis, and we revised it recently to take account of the statutory scheme. I think there's more to be done, and I've asked my team to start looking at that now. Ideally what we would like is we'd like two separate, more detailed documents. We would have one which was citizen facing, similar to what's already there, but making it very clear what they can get, giving them links through to the various services that they can use. And then we would also want one which is more business facing, and which will probably be cited on NI Business Info. We've got very good models for both those documents from Scotland, and the team are now looking to see it at Northern Irelandising those, and we work with colleagues on the health side who have responsibility for the policy to make sure that they are wholly accurate. In relation to finding things on NI Direct, yes, that is an issue that has been raised with us before, and we will speak to the NI Direct team directly to see how we can maybe raise the priority or spotlight this information, particularly during the first, say, 4 weeks of its operation.
Okay, thank you very much. Thank you, Chair.
Thank you. And a supplementary to Colin's question there is around the issue of, and this is not directly related to the COVID cert for the purposes we're talking today, but for example, and there's a couple of issues that should be flagged and should be followed up by yourselves. For example, I'm aware of a query from a 14-year-old going to Spain and needing a certificate for there. How do they access those? So not for domestic use, but for travel use. And then in relation to the COVID certification for here, and I predict this will become an issue for many people. People once again are struggling. People who got the first vaccine in England where they were a student, and then their second vaccine here, or vice versa, or another jurisdiction. How is that? And will you put a dedicated resource in to deal and address those queries, because they will arise?
In terms of the travel cert, I know that there is work going on at a UK level on that, because Spain's not the only country that's starting to require travel certifications for children and young people. But I am not involved in that now, so I'm not sure what the detail is, but I do know that they are looking at it. On the home side, that is the problem of people getting a vaccine in two jurisdictions is a challenge, and it's because the health records in each jurisdiction are standalone and don't share information with one another. I will look into that with the technical team and come back to committee on what the process is for a person to be able to evidence that, and how that's going to be dealt with in the coming weeks. So I'm happy to come back on that one.
Okay, and I think it's important to bear in mind that many of the decisions around travel were based on the common travel area and the fact that we had such integrated, people travelling for work across. So we need to make sure that all of the other schemes then take that into account and are able to deal with it. So thank you for that commitment to look at that, Elaine. I'm going then to Deborah. Go ahead, Deborah, please.
Thank you, Chair. Look, it all feels a wee bit cart before the horse. I mean, just as a comment before I go into my questions, having things published on the same day that businesses are meant to start getting things in place can be very difficult, and there's an awful lot of confusion around it and uncertainty. And I think that uncertainty is a thing that sometimes really impacts upon businesses and impacts upon the public as well. I would have concerns like Paula's point there in relation to the older people. I'm glad to hear that you're engaging with the Older Persons Commissioner. I have concerns around staffing levels in terms of the helpline to ensure people get their COVID vaccination certificates. Will there be enough staff manning that? We're coming up to the Christmas period now. I know my constituency office will be helping people in terms of anybody that comes forward who wants to get their passport. But when my office closes, what happens then? Where will those people go? Are they going to be able to get through okay on the helplines? And I'm wondering about the interim period for that card as well. That's vitally important that we have that information. Then I'm looking at the enforcement and things like that. Given that the regulations do not assign one specific body or individual to apply the requirements, is there not a risk that the enforcement will simply not be feasible and that confusion will abound over that?
Okay. So coming back to the timing of publication of things, I completely agree. It's not ideal for businesses to operate in this way, and to have the guidance published on Monday at the same time as the regulations is very difficult. What we tried to do to mitigate that, because there really was no alternative for us, just with the pace of things, but what we tried to do to make it a little bit easier was to make sure that the policy intent was well publicised. So from the time of the executive agreement on the 17th of November, we started to work on the FAQs, and we got those online quite quickly, which stated what the policy was going to be. So whilst we couldn't publish the regulations in detail or what the guidance was going to be, that was there. The technical team, I know, began their industry engagement on the Verifier app a lot sooner as well. So that was already happening. Businesses could get a briefing on how to comply, and they could hear how that worked and on how the app was to be used and downloaded. So there was work to try to mitigate against the fact that we weren't publishing the regulation guidance until the same time as the regulations. But I do accept that point, and I do accept it's not ideal. Helpline staffing, I think we kind of always expected there would be a bit of a rush once the regulations were made about getting the certifications and the helpline. And I know that there is a well-staffed helpline at the moment. I can come back to committee on kind of specific figures on that if it's helpful when I'm coming back on the other issues. So I'm happy to do that. On the interim period for the use of the card, we don't have in mind a fixed date for when we will remove that. And it's very much going to be in consultation with not just the industry, but also with our own technical team, because we can't remove it until we are fully confident that those people have been able to get paper certifications if they need them. And that's the crux. And the other thing, part of the other reason is for allowing people time to get evidence of their medical exemption, because the process for that is opening next week. So we won't turn it off until we're absolutely convinced that people don't need it. And we will give notice as well.
If I can come in, Deborah, just in relation to the enforcement side of things, it's true that the regulations aren't prescriptive about who is responsible for what areas, but in practice there are allocations. I mean, the police would be the lead agency in relation to licensed hospitality, for example. That interface or that sort of area will be monitored by the task force's adherence group, where local government, health and safety executive, and police are all represented. So that's an area which we will be keeping under close scrutiny, again, particularly during the first few weeks of operation. And
just for clarity as well, I'm hearing back from businesses that they're going to have to employ extra people to man their doors. Do they have to ask people coming to is it point of entry at the doors? Because that's going to impact upon businesses, obviously, that have multiple doors for point of entry. So just for complete clarity, is a point of entry, is it a till? Is it when they're in their seats? Where do businesses have to ask for, identification?
Yes, it is. It is point of entry. That's another one of the reasons why it's licensed hospitality, because the issues with mixed trading venues and the likes of places that like fast food restaurants where you go in and you order and then you sit down is one of the challenges. So at the moment it is point of entry. In terms of the timing, this is why we are promoting as far as possible the use of the Verifier app. If businesses download the COVID certification Verifier app and use that, it's literally seconds to verify a person who has a domestic certification on their smartphone or any paper evidence with a QR code. So it's not only having to have it on the smartphone speeds things up. And the types of things that will be accepted on the Verifier app are international certificates with QR codes and printed copies of the exemption I referred to earlier, or the paper copy I referred to earlier for those people that don't have smartphones. All of those can be scanned by the Verifier app, and the only thing that needs to be checked is some of those. Well, sometimes the Verifier app will say to the person who is doing the scanning to check an ID of one of the people, but mostly it's a green tick and you're straight through. So it's very fast, and the more the Verifier app is used, the less time it will take to get people through the doors.
Okay, thank you.
Okay, thank you.
Thanks, Deborah. Going to Jerry Carroll. Jerry, go ahead.
Thanks, Chair. Thanks, Elaine. I've got a few questions here, Chair, so I'll be as quick as I can. Just to say from the outset, I have and we've always been enthusiastic supporters of the vaccine. People should get it. Everybody should get it, obviously, unless there's any underlying medical conditions preventing them from doing so. But I'm very concerned about this scheme generally, but the way it's being presented. And that it's being presented somewhat as a bit of a silver bullet, and frankly it isn't and can't be. In the south, obviously, a similar scheme was implemented and cases rocketed. I've noted from Simon Williams from Swann University has said that there's only been a slight increase at best of vaccination in Scotland from the rollout of the scheme, and others have a more critical take on it. So I think those points just have to be made just at the start. Just in regard to hospitality, because from what I've gathered, and apologies if I picked that up wrong, but this is essentially a plan in the main to hospitality venues, aside from, I think, places of worship as well. But we have a situation where there's legally no requirement to socially distance in hospitality venues. That SR was made and passed a week before this current SR was led. So essentially, and maybe Elaine, just to kind of confirm this, you could be in a situation where two people could be doubly vaxxed, could have a copy of a certificate to show that, but they could be sitting next to somebody in a hospitality venue with COVID, and they could therefore obviously pass it on to them. Is that a possibility?
Well, yeah, it is a possibility. That you mentioned that this is being presented as a silver bullet, and you're right, it's not. And it's certainly from our communications, we've tried to emphasise that this is another weapon in the arsenal against COVID, and that's very much how we have to see it. Face coverings, hand sanitisation, basic hygiene and social distancing where possible are still important elements of this, of the whole thing. In terms of the increase in vaccination elsewhere, I have to sort of emphasise that that's not a policy objective for us. This isn't being introduced to increase vaccination uptake, and we have to be, whilst it might well be a secondary benefit, and we don't deny that, that's not what we're trying to achieve with this. This is very much about making those venues safer where we can, and trying to minimise community transmission of the virus.
Yeah, thanks. Oh, sorry, go ahead. Sorry.
No, I was just going to say I think I've addressed everything, but if I haven't, please let me know.
Yeah, no, thanks. A couple other questions, but like I said, I'll be quick as I can. And just the proof of negative test. I mean, just a bit of clarity. Sorry, because I'm still just trying to ascertain this. Does it have to be digital? Is there any requirement of photo identification? And for example, can people take a negative test, take a test with a negative result at home, and either bring that physically or bring a copy of that through a photograph, with a time or date on it. So I think that needs to be clarified as well. And then just one final question after that. Thanks.
Okay, so the negative LFD result has to be reported through to the NHS reporting system, and it is only available digitally at the moment. The reason for that is then that person will receive a notification, and that notification is what is the evidence they have to present with photographic identification. If they aren't able to upload an LFD test, people who aren't resident in the UK won't be able to upload an LFD test onto the NHS system. They will have to do it on site, and there is provision for on-site LFD testing. So that is there, but very much that's up to businesses whether they operate that.
And there's no idea how many more businesses will take up that on-site testing? No.
No, I don't know, Peter. Do you have any information on the large event sector? Because I know that they do it, but I don't. It is so many small numbers that they don't need to do very many of them, and that's even for large events.
Yeah, the feedback that we got from the event sector was that the really big operators were doing on-site testing, but very quickly, even once the scheme was being operated voluntarily, the need for that reduced down to fractions of a percent. So it is something that we'll keep under review with the other sectors that are now operating it. But it seems once the message gets through to individuals, it seems to become less essential.
Thanks. Yeah, I think there's also an issue, Elaine and Peter. I mean, the fact that it's a digital proof, that requires, or is rather, a barrier for people who don't have access to a phone or internet. And I think that's a big issue. I know, like the CAJ, and I don't know if any other human rights organisations maybe can speak to this, have expressed concern about people being I don't want to misquote them, but people who don't have access to phones or apps can be basically negatively impacted by this scheme. So there's big questions around that. People who don't have secure immigration status and people who are marginalised. So maybe come back on that. And my final question, just, I mean, you said yourself, Elaine, this isn't being done sort of to increase vaccination itself, and you say that may be an after result. I'm really concerned that it's kind of being used as maybe the silver bullet to do that. But also, I'm not aware, I'm happy to be corrected, of any work being done by the department or trust to ascertain why people aren't vaccinated. So we have a cohort, small, I think, cohort of people who are anti-vax, and they're obviously incorrect and they shouldn't be. But there's a group of people who are unsure, could be convinced. People who were pregnant, obviously were unsure and were told at the start not to get vaccinated. So are we aware, or do you have evidence of the broad reasons why people haven't been vaccinated, and any work being done by the department in that regard? Thanks.
Okay. I'll just briefly come back to the LFD test and the digital. There isn't really much we can do on the LFD test other than allow on-site testing for a non-digital route. And the difficulty that we find with the LFD test is we have to make sure that the ability or the way that people might sort of game the system is minimized as far as possible. So we have to make sure as far as we can that people are genuinely taking tests and genuinely that it's a negative result. Now, this isn't perfect. I recognise that, and we're working on across the UK on the notification system to try to see if there's a way to build in more than scanning of the QR code, so that you actually scan the test and the result can be verified. So there is work being done on improving it, but there isn't really a way for us to do anything non-digital in this space other than on-site testing that doesn't leave it open to abuse. On terms of the vaccination, that's not my area at all, so I'm not even going to try and guess an answer on what might be going on. So I'm happy to get input from colleagues and put that back into the response along with the other issues.
Okay, thank you. Okay, Pam, go ahead, please.
Thanks, Chair, and thank you again, Elaine and Peter, for your time today. Just two questions for you. One's around clarity again. I did ask in the back of the previous question around church events, but obviously in Schedule 2A, it does give a general exemption for communal work. Sorry.
Yeah. Worship or communal activity. Yeah.
My dog's barking, but no, I was just wanting to check that general exemption that's there in Schedule 2A around communal worship or communal activities in a place of worship. So surely that that not give exemption to churches for their, not just their services, but their other activities? It does.
It does for the events, but not if they serve alcohol. So if they have an event with no alcohol, yes, that would cover it. But if they serve alcohol, it only can be done as part of a religious service.
That's
sorry.
Brilliant.
That's right.
Thank you for that clarity. I appreciate that. And
sorry, Pam, if I can come in very quickly on that, I'm probably the part of the task force that's leading a lot of the engagement, and we do plan to have another meeting with faith leaders hopefully next week to talk to them around that, because although there is an exemption there, we do want to sort of talk to them about their appetite for applying COVID certs voluntarily, particularly for the bigger events that they might be having in their run up to Christmas. Whenever we met with them before, there was mixed opinions. So some churches felt that was something that they would be keen to do to protect their congregation. Others less sure, because they didn't want to do anything that would stop people getting access to important religious services. But we will continue that conversation next week, hopefully.
Okay, appreciate that. Thank you, Peter. My other question was around the lateral flow test and the producing a negative test as evidence, and I am a bit confused with that. I wonder if somebody could just walk me through the process of how that works in practice, and can you use how do you prove that the test has been taken within 48 hours? Can you use an older test? Can you repeatedly use the same negative test? So just like some clarity, if you want to walk us through the practicality of how that will actually work.
Yeah. So the negative LFD test. So once you've obtained the LFD test, you take the test. So there's instructions in the kit, and you have to do the swab yourself from your throat and your nose, and you use the liquid, and it's all step by step and how you get the result of the test. Once you have that, you go onto the NHS reporting system. And if you want, you can create an account. So if you're going to do this regularly, if not, you can just report a single result. Whenever you go to report that, you can only report tests taken either today or yesterday. So you can't report a test taken further back. And it will ask you which day the test was taken on. And you put that in, you put in your name and your details. If you want, you can link it to your health and care number. You don't have to, but you can do. If you're in a workplace scheme, there will be a code that your employer has given you, which you can enter, and that will be recorded against your workplace testing. None of that is mandatory. You can just report the result. You select three options when you're reporting the result. It's either positive, it's negative, or it's inconclusive. And when you report the result, it will ask you, do you want to receive a notification? That's a new step, which I discovered this morning. Hadn't seen it before, and it threw me completely. But for the purposes of this, for certification, if you're taking it to get into somewhere, you will need to click yes, you do want a notification. And an email, depending what information you put through. And on that notification is the date of the test. There's no time of the test, there's only the day. So if you're putting in going to an event, say Saturday lunchtime, you can't present a Thursday test. So whilst the regulations say 48 hours, there is a bit of it's more like a 2-day, because you won't be able to, if you put a date of Thursday, sorry, I'm thinking it the wrong way. Yes, if you put a date of Thursday, it could be taken more than 48 hours before. So it will have to be that day or the day before that's the date of the test. And we're looking with working on whether we need to amend the regs on that, or what way we want to handle that. But because there's no time on the test, it's only the date that is shown. So I think that pretty much covers it end to end.
Okay, thank you for that, Elaine. Can I just ask one more question that's in around what circumstances the department envisages someone under 18 enforcing requirements? And could you tell me if the equality screening covered that element?
So in terms of enforcement for under 18, so they don't need to prove anything. So do you mean if someone's trying to enforce against them and they're under 18?
I mean, if somebody is basically trying to enforce the COVID certification at the door and they are under 18.
Oh, right. Okay. It's not even something that we'd considered at all. So I'm happy to go away and look at that. I don't know if there'd be any particular issues with it, but I certainly will check from a data perspective, and certainly for the downloading of the app, if there's any issues from under 18s downloading the verifier app or anything like that. So yeah, we'll definitely look into that with the data protection officer.
And so presumably the quality screening won't have covered the element if it hasn't been thought of.
The equality screening is more about impact of users, so the citizen having to verify before they go and do something, as opposed to the person who's working for the business and doing the certification itself. So that wouldn't really be covered in equality normally, but certainly we'll go away and have a think about it, and we'll talk to the data protection officer, and we'll have a think if there's any other issues other than data protection that raises. So we'll definitely we'll look into that one. Yeah.
Okay, thank you, Elaine. Thanks, Chair.
Thank you. Yeah, thank you, Elaine. I just want to pick up with you around the issue of languages for the LFD testing, and I suppose the LFD testing process is complicated enough. Like I have to follow it step by step, and if I didn't do one for another month, I would have to follow it step by step again, and it's tricky enough. Is that available in minority languages? The
guidance for the test itself?
Yes, the instructions
I'm not
for
sure.
the test.
Yeah, I'll go away
check
and
that
find
for
out.
me. Yeah, do check that as a matter of urgency. And actually, there's a real urgency around the fact that some of those minority language communities are actually involved in domiciliary care, a lot of food production, and the vulnerabilities. And I also want to reiterate a point I've made a few times. A lot of the East Timor population, certainly in my constituency and beyond, speak Tetum rather than Portuguese. I know there has been information put out in Portuguese before, but they actually speak a different language, a lot of them, and it's Tetum. So I'd like that checked out and included as part of any ongoing instructions. Okay. And also, when I raised this last week again, is it available in Braille? LFD test instructions? Because I met with the Royal National Institute for the Blind, and that's another issue. And indeed, any sensory issue that might impact communication needs to be considered very carefully around those complex instructions.
Yeah. Okay. Yeah.
Okay. Give that some. And the other thing, and I'll finish on this. I'll finish on this for now, is around the whole area of communication, and I do think that is crucial, that there is a clear communication around how this is going to impact and how people can comply with it. And I think the vast majority of people here understand that in the circumstances we're in, and potentially the circumstances we're facing into, slight improvements are actually valuable, and our health service and our population deserve any slight improvements we can get. I think should not be dismissed. And in fact, I would see it as myself. I see it as a minimalist enough approach in that sense. But we should certainly take the advantage of it. Essentially, there's a number of ways you can try to demonstrate that you don't actively have COVID before going into a crowded setting in somewhere you don't need to be. I mean, we're not talking here about necessary travel, public transport, and things like that. So, but I do think there's a huge onus on yourselves to catch up in terms of communication. And I'm aware, even this morning, there's a message circulating widely claiming that there's going to be a whole range of other measures brought in. I believe it's disinformation, but I think the department and anybody involved in this, including the executive and anyone else who can help here, needs to massively push back and put out the correct information in a way that not only reassures people, but provides them with the information to allow them to push back on nonsense. And some of it is nonsense. And I accept there are genuine concerns as well, but there's a lot of it out there that's pure nonsense. There appears to be a disinformation campaign even as we speak, and that needs to be challenged and tackled. And that's an area that needs to be looked at. So listen, thank you for coming. I don't see any other indications at this point from members there, but thank you for coming. And thank you. We'll go ahead with the rest of our meeting, but we can let you go for now. Thank you, Peter and Elaine.
Thank you.
Okay. Okay. So members, any further issues members wish to raise in relation to that rule, and then I think we should defer formal consideration till next week, just so we get some of those additional pieces of information back to us. So, Colin, I see you're indicating there.
Yeah, I was just wondering, I didn't want to hog the questions, but is there a way of maybe getting a phone number for some sort of helpline that businesses could maybe ring into, that if any of us are contacted by businesses, we can pass on a phone number that would give them a direct line to get help and assistance? And if we don't give this consideration today, does this impact it being presented in the Assembly on Tuesday?
So I'll check with the clerk on that. My understanding is that it doesn't. Clerk?
No, it doesn't. It doesn't. It's going through the confirmatory procedure, so it's a case of the committee can make a decision on this rule next week that allows it to give its view to the Assembly on the, I think it's down to the Monday, I think.
Okay, Jerry?
Yes, sure. Sorry, I missed it in the presentation, but did Elaine say that the quality screening hasn't came back or hasn't been completed? And if that was the case, can we insist that is shared with the committee?
Yeah, Clerk.
I think they confirmed that the equality screening was undertaken, so it was. That was indicated early on, but we can confirm that.
Thanks, Keith. Sorry, just a clarification then. Can we ask what human rights concerns were raised with the department? Because I know CAJ raised some concerns. I'm unaware of any other organisation, but I think it'd be useful for us to know. And that was around people who are primarily not born here and are asylum seekers and who have unsecure status. So in regards to those aspects more than anything else. Thanks.
Sure. Thank you, Alan. Yeah, I've Alan first of all, and then I think I hear from Carol, but I'll take Alan in first.
Yes, sure. It's just it's a query I had yesterday, a phone call from a gentleman in the hospitality trade, and he was asking if it would be possible for the legislation around the passports to include that in sort of nightclub settings and so forth, that the person that would be checking the paperwork or the app would be a certified doorman rather than some young member of staff been thrown in to do the job. I could see that in certain circumstances that would have certain merit, but I can imagine it also would present then more difficulties for hospitality that don't employ doormen. So, but it was just a suggestion that he was putting, that he thought it should be included in the legislation that those in licensed premises should be certified doormen.
So we can seek some clarity on that, Clerk. Would that be correct? Although I do recognise that there could be that additional difficulty, but we can certainly, I suppose, clarify. Did I hear, Pam, were you looking in there?
Carol?
Or Carol, sorry, Carol, it was Carol. Yeah, go ahead.
Sorry, Chair. So the issue around, Elaine clearly said that an equality screening exercise had been taken and didn't feel the need for an full equality impact assessment. Because I noted that, I put that down. So I think we need to see why an EQIA wasn't necessary in this. What the details of the screening exercise were to make the decision not to have the full EQIA, I think, is in the public interest in this one, to be honest.
Okay, members, content with that additional clarity? Yeah. Okay, members, so listen, we can come back, as I said, there is time to come back with those further pieces of information, and we can come back next week for a formal consideration of this one. Okay, thank you. So I'm going to check with the clerk again then. Are we in a position to take the briefing from the ambulance service, clerk?
Yeah, Michael's on there, so we're going to try and bring him up and see if the camera and the microphone's working.
Okay.
Hi, Michael. You able to hear us okay?
I can hear you. Can you hear me?
Yes, we can hear you okay, so we can.
Okay, thank you.
Okay, Michael, your appearance is long awaited at this stage now, given the circumstances. But anyway, we're looking forward to the session with yourself. do we have Rosie Byrne on the line as well, or?
We do apologies, Chair. We had some difficulty getting on at the time we were asked at 11 o'clock. We had it set up in a room that we're socially distanced, and it was on a camera mounted on the wall. You could see all of us, but we just couldn't get that to work. So we're on a laptop. So I've got Rosie Byrne, Director of Operations, and Maxine Paterson, Director of Planning and Performance, both with me. But I'm afraid you're just going to hear them and not see them. And I can assure you that's probably the poorer option. It might have been better putting the camera on one of them rather than me.
Okay, well, we'll work with it, but yes, and I'm certain that anticipation has seasoned the expectation, and that will be through the roof at this stage, Michael. So good luck. Okay, so I welcome you all. I welcome you all to the committee this morning, and I'll go ahead back to yourself, Michael. If you would give us your opening remarks or remarks from Rosie or Maxine, and then we'll go to members' questions. Thank you.
Okay, thanks, Chair, and good afternoon to you and to all of the committee members, and thank you for this opportunity to brief the committee on the pressures currently being faced by the ambulance service. With your agreement, Chair, I'm going to make just a very few brief introductory remarks to allow almost all of the time for committee members to ask questions, which is probably more useful for you. So it'll just be me, makes a few introductory remarks, but I'll be certainly looking to Rosie and Maxine to come in and pick up on some of the questions. We sent you a couple of documents, and they were just by way of background only. That was our most recent performance report presented to the NIAS Trust Board in October, which provides some detail on the pressures that the service is facing and the actions that we are taking to address those, and also the Trust's COVID surge and winter resilience plan that we submitted to the department. We don't intend to talk to either of those documents in any detail, but they may contain information that is useful to you to inform the discussion. We last briefed this committee almost exactly this time last year, and it's been a particularly difficult 12 months since then. I would say the last 4 to 5 months have been the most challenging period that the ambulance service has had throughout the whole pandemic, and there are a number of reasons for that. Firstly, our demand has now returned to pre-COVID levels, and in fact, it is now higher. We received 13% more 999 calls in October 21 than we did in October 19 before the pandemic. Secondly, we continue to have a large number of staff unavailable for work. At any time, we have approximately 20% of our operational staff who are unavailable to work, either through what might be considered normal sickness absence or COVID-related reasons, such as the need to self-isolate. And it's roughly equal in terms of the numbers for both ordinary sickness and COVID-related absence. So this makes our service even more reliant on staff working overtime in order to provide the required level of cover. And that's simply unsustainable. It's been well said by all organisations, about all staff groups, that staff are exhausted. I feel that's almost become said so much it's losing its impact, but it really is the case, and we cannot expect our staff to keep working at the level that they have been over the last number of months. And then thirdly, the wider unscheduled care pressures across the system that have been well documented have resulted in increasingly long delays in handing patients arriving by ambulance over to emergency departments. On average, around 20% of our emergency ambulance capacity is lost every day waiting outside emergency departments to bring patients in. And obviously that makes them unavailable to respond to calls waiting in the community when they're doing that. Many of our crews now would only respond to 1 or 2 calls during a 12-hour shift. Before the pandemic, that would have been between 6 and 8 calls during a shift. So these factors are all leading to increased response times for patients waiting for an ambulance in the community. Response times in particular for categories 2 and 3 patients, and those are very, very ill patients. Category 1 is the very small number who've got an immediately life-threatening condition. Category 2 and Category 3 are still very ill patients, and the response times to those have increased significantly over the last year. And finally, it's also having a very significant impact on our staff. They continue to do the very best they can, but I know that they are concerned that they are unable to provide the standard of care that they want to and that people need, frankly. They also experience regular late finishes to their shifts and late or on occasions no breaks during a 12-hour shift, things that are of a real concern to me and that we're trying our best to address. And that's all taking its toll on our staff, and I really do want to take this opportunity to place on record how grateful I am to them for everything they continue to do to try to provide the best care they can in extremely challenging circumstances. They're an extremely dedicated group of healthcare professionals who serve our community very well. So thank you, Chair and committee members. That's all I wanted to say by way of some introductory remarks, and we're obviously now very happy to try to answer your questions.
Okay, thank you, Michael. So again, I'll rattle through the questions fairly succinctly because we do have a fair bit to cover, I suspect, and I want to give everyone as good an opportunity as possible. So a few from myself first, and then I'll go to members and other members. So in relation to the workforce, how many staff do you think you're going to need in over the coming months, or how many staff do you think you're down in relation to what you need over the next coming months?
Well, we don't have sufficient staff to meet the demand in ordinary circumstances. I think I probably reported that previously, that we had an independent review carried out that showed we need an extra 325 operational staff and other corporate support staff to deal with such an increase. So we still very much need that. But the fact that we're down at any point in time 20%, now there'll always be an element of sick absence, a background level. We had got our sick absence down to about 8% about a year, 18 months ago. And you have to always plan for a certain element of sickness. Their staff will be sick. But when it's sitting at 20%, that's what makes the delivery week in, day out of providing an appropriate level of ambulance cover very, very difficult. I don't think that is likely to change over this winter with the number of people who will have to self-isolate at any time, particularly given concerns about new variants and so on. So we will need over this winter time to continue to rely on the staff who are able to work to do a little extra in terms of overtime, and we will continue to make use of voluntary and private ambulance providers to also make up any gap. But longer term, we continue to need in the order of over 325 staff to provide the satisfactory level of response time right across the region.
And linked to that, Michael, you've mentioned in your performance report that training programs have had to be interrupted twice as a result of COVID. So what impact has that had on delays to training and on delays then into staff feeding through into the service?
That was one of the most difficult decisions we've had to take, Chair, during this. Staff who had applied for and commenced a foundation degree in paramedicine, who are our existing emergency medical technicians, and interrupting that to put them back out on operational shifts. I have to say they did it extremely willingly, but they were clearly disappointed. That did have a knock-on impact. So the current cohort of foundation degree students, they're not due to graduate until January. That would have been around the summer time. Otherwise, we then would have started the fourth cohort in August. There was always the requirement that we had to do any in-house paramedic training by September 2021. At that stage, the HCPC changed the regulations and it moved to the new BSc, which has started up at UU in September. But we got permission from HCPC to extend that to March because of the pause. So we are still planning to commence a fourth and final cohort of foundation degree paramedic training in February to be in before that March window, because that really is the last one. So it has delayed the timing for having those paramedics in. And it's that tension and that balance that we have to manage between today's pressures and today's problems, as opposed to having the right number of staffing in a year's time. And we've tried to strike an appropriate balance in that. All of the training is has been back in now for quite some time, but there has been a delay as a result.
Okay, thank you. And the southern region, Michael, has a long history, and I'm well aware, and I'm sure other representatives are, a long history of poor and inadequate staffing levels. Is there and I'm not asking this question from an insular perspective either, because the impact of that then is that very often staff have to be drawn in teams from other areas, leaving cover scarce more widely across the region. So have those, the reasons why that's historically and continues to be the case, been identified, and is there anything in place to try to address that continuing weakness, it would appear?
Well, I'll ask Rosie Byrne, Director of Operations, to say something about that in a moment, Chair. But we don't have a understaffing position in the Southern Division. Actually, the division at the moment that we have most difficulties in staffing is the Southeastern Division, which works very closely with our Belfast division, but it does cover obviously large areas like the Ards Peninsula and down to Newcastle. The Southern Division, we would aim to put out in the Southern Division around 13 or 14 ambulances each day shift and slightly less at night. We have difficulties at different times in each division, and there have been times when the Southern Division has been affected. That 13 or 14 ambulances across the whole division includes, Craigavon, Dungannon, Armagh, Newry, Kilkeel. It's a wide area, and each of those would only have one or two ambulances operating out of them. So what tends to happen is if you've got a number of staff off sick on a shift, that's when you hear stories such as there are no ambulances working out of a particular station. But we manage the division as a whole, and indeed then we manage the service as a whole, and bring in the ambulances, the nearest available ambulance to respond to a call. But that undoubtedly, again, does mean the crews are being stretched and journey times are longer. But I will ask Rosie if there's anything particular you want to say about the Southern Division.
Thank you, Michael, and thank you, Chair. As Michael has said, I personally wouldn't have chosen the Southern Division as one to pick out as an outlier in staffing. But as Michael has very clearly articulated, we do rely on managing the division as an entire division. We do rely on cross-divisional cover for our co-terminus areas to provide cover. Where we have times of peak drops in demand, or drops in our capacity, I should say, we also then rely, as Michael has said, on our independent providers. We have also moved some of our PCS crews over to provide A&E support, not just in Southern Division, across all divisions, because our acute hospital trusts have changed how they manage their, for example, outpatient activities. So we've prioritised some outpatient activity for key conditions such as cancers, red flags, dialysis, etc., to supplement A&E support. So we look at it across our A&E support, our PCS support, and our independence to maximise the cover that we can.
Okay, thank you. Yeah, and I suppose it could be a factor that where I'm located means I'm picking up on that sense, but I do pick up on it over a period of time. I have picked up, but I'm reassured to hear that that's not actually the case. Final one from me then before I move on to other members is around critical incidents or adverse incidents maybe. Have there been adverse incidents over the past number of months that you're looking at when a crew weren't available to carry out CPR, and do you monitor and measure, are those on the increase, or is there any trends around those adverse incidents, Michael?
Without a doubt, Chair, the increase in response times over the last year have led to an increase in complaints and also serious adverse incidents. Now, it is difficult to put a precise cause and effect relationship, because we in the background have also been, over the last couple of years, really encouraging our staff to report adverse incidents. There was previously quite a low level of reporting of serious adverse incidents in the ambulance service, and we are keen that they are reported and the staff learn from them. We all learn from them, we make changes, and that it is, there's no worry from staff about reporting them in terms of thinking there'll be blame, etc. So it's quite difficult when you are encouraging reporting and then you see an increase to link that directly to response times as opposed to increased awareness. But I think it's fair to say, given the nature of the incidents that are being reported, we are seeing an increased number of serious adverse incidents associated with delays in us arriving on scene. These are time critical incidents. That there's a reason why there's a response time of 8 minutes for a Category 1 call and 18 minutes for a Category 2. They're not arbitrary. They're there because that gives patients the best outcome. And if we are taking much longer to get there, there is, of course, a risk of increased harm, and that in some cases feeds its way through to serious adverse incidents. I think Rosie might want again to add some specifics to that.
Thank you, Michael. Thank you, Chair. So I would just reassure committee that we do have mechanisms in place for investigations, both of our complaints and our SAIs. When we receive complaints, we, if they are directly linked to delay in response times, we have a weekly meeting whereby we review all our complaints and our SAIs. I have to say we do review our compliments at that weekly meeting as well, but we review all our complaints and our to determine whether any of them are potential serious adverse incidents, and if they meet the criteria for that. So I think it would be wrong and it would be kind of too simplistic to say that SAIs are all the result of delayed responses and delayed handovers. But we have a robust mechanism in place whereby we look at all of those, and as Michael has said, take the learning from them as to how we can improve and reduce the poor outcomes that could be attributed.
Okay, well, could you maybe send us on a breakdown of how many have been progressed to an SAI level, say over the past 12 months, just so we get an idea of how many we're talking, and kind of that's something we can keep an eye on in that sense.
Yep.
Okay. Yep. Thank you, Michael. And I'm going then to firstly to Colin, then Paula, then Pam, then Deborah. So go ahead, Colin, please. And Carol. Sorry, I have Carol then as well. So back to Colin.
Thank you very much, Chair, and thank you to Michael and the team. I just want to say that I'm always amazed at the work that our paramedics and our full ambulance team do. You work under very, very difficult circumstances, and I've met with you before, Michael, where I've said, if it was me, I would double your budget. I would want to see double your staff and complement. I would want to see a fully enhanced ambulance service, because if we can get the people when they're needed most, and then get them prioritised and triaged and into the care and hospitals, I think that the community would feel a lot safer. Michael, you mentioned, and so just on the budget, if my memory is right, the budget for ambulance service about 50 something million out of a 6 point something billion budget that we have for our health service. Yet increasingly you're becoming the front step, you're becoming the first place where a lot of people are interacting, and you're under a lot of pressure. But I know that there's workforce issues that you need to work through there as well. But
just on that, Colin, and thank you for your comments and your support, which we obviously welcome. Our budget is modest, but thankfully it is a bit more than that. We've got about a £90 million recurrent budget, and we have been consistently getting over 10 million non-recurrent each year. So we operate with around about 100 million, of which about 90 million is recurrent. We need a significant uplift in order to provide those 320 staff that I mentioned to the chair.
Yeah, and you mentioned earlier, and I missed just the figure that you had said because of the sound quality. But what I mean in terms of the response times, which are increasing, what is it that's causing them, and what was that percentage that you gave in terms of the amount of time that people our ambulances are waiting at hospitals?
Yes, I mentioned three things that are all driving the increasing response time, Colin, and that is an increasing demand. Now, we've got to remember that demand fell considerably during the early days of the pandemic, and we are now seeing it completely back at pre-pandemic levels. So that's one. The availability of our staff is clearly the second. If we don't have enough people to fill all of our shifts every week, that impacts on response times. Actually, across the working week, our cover's not bad. We're usually about 94-95%, but there's big drops and big differences in certain areas on certain days and certain shifts. So you might see a Saturday night in a division where it's only 75%, but it averages across the region at 95%, and that's only by staff working a lot of overtime. The factor that is making the biggest or having the biggest impact on response times currently is the amount of time we are losing that we cannot respond when our ambulances are waiting outside emergency departments to hand over their patients. That is a direct result of the pandemic. We still had handover issues before the pandemic, but our staff would have queued in a corridor and they would have doubled or trebled up. So if I arrive with my patient and an ambulance arrives after me, I might look after their patient as well. And you're in a hospital setting, and that was done. Not ideal, but it was safe to do so. We can't queue in hospital corridors since the pandemic. So if the hospital is so busy, which they are, and I know the reasons for that, and I know the challenges and the pressures that my colleagues in the other acute trusts are dealing with, if that means that they simply have no room to take anybody in, our staff wait with the patients in an ambulance. And the figure I give is that on average, every day we lose 20% of our capacity to while waiting outside in ambulances. The average delay in the month of October was 1 hour and 13. It should be 15 minutes to hand over a patient. The average delay in October was 1 hour and 13. Every day of the week there will be patients wait 4, 5, 6 hours, and on rare occasions there are patients who wait longer than that. That led to the other figure that I mentioned, that whereas a crew who came on and do a 12-hour shift, the last time I went out with a crew was before the pandemic, and I worked a 12-hour shift with them, as did Rosie. And you go to 6, 7, 8 calls, you see a good variety of the types of issues they deal with. Now in a 12-hour shift, our crews typically do 1 or 2 calls, and they spend the rest of their time waiting. That's hugely frustrating for them, and it's also impacting, obviously, on people who are waiting. And there's other issues. We have, the chairman asked about training. We have got paramedics in training at the minute who spend a lot of time out on placement. And if they're only seeing 2 calls during a 12-hour shift in placement, they're not getting the same level of experience and learning as they would if they saw 6 or 7. So it's taking them longer to see the full breadth of conditions that they will come across.
And of course, the ambulance sitting outside an emergency department is predicated on that emergency department being open. And we had the experience there recently where Craigavon had to actually close its doors and not take any of the calls and implement a bypass, and because of the pressures that they were under. I mean, can you talk us through what happened there, the impact of that upon your service in terms of diverting ambulances further away? And I mean, were any lives at danger as a result of that?
Well, it's probably important to say, Colin, that every day of the week, our control room do what we call smoothing, and that's in agreement with the other trusts. So we will try to balance pressures. So if we see, as we do every day, an emergency department under significant pressure, we will take a conscious decision for a while to try to ease off there. And the patient condition always comes first, and there's some patients, doesn't matter how busy it is, we've got to take them to the nearest department. But we will do that moving to try to equalise pressures to some extent. On occasions, and it's rare, but it's what happened the weekend you're referring to, on occasions an emergency department is so under pressure, smoothing just isn't going to give them the release that they need, and we need to do something more to decongest that emergency department. Those are regional discussions and regional decisions taken. So we will have been party to regional calls, and we were at that weekend and leading up to it, where there was an agreement and an understanding across the system that in order to decongest Craigavon, that other EDs would need to take more patients. The only way there is to do that is to encourage walk-ins, people who self-present, to please don't go there, go somewhere else, and that is very difficult to change people's patterns and behaviours, or the ambulance service take them. So that was what was agreed that weekend. Only standbys, and those are the very, very seriously ill, category 1, who need resuscitation. Only standbys were to go to Craigavon, and for a large part of the Sunday, I think it was, and again on the Monday, we took patients who would have gone to Craigavon. We took them to the Southwest Acute Hospital, to the Royal, and to Antrim. You asked about the impact on our service. The impact on our service is that all of our ambulances, or most of our ambulances, who would have been within that southern division that the chair was asking about earlier, because they would have gone to Craigavon, been dispatched to the next call, most likely in the Southern Division area. They are out of division. When they clear at a call at, let's say, Antrim, if they're the next available ambulance to go to Ballymena, they will be sent. They are not just sent back down to the southern area to wait. So it does mean that our ambulances are out of area for a lot of the time, and that obviously again leads to increased response times for people in that area. There would not have been the normal volume of ambulances within close proximity to calls if they required a very, very urgent call. There's a longer journey time, so that clearly has the potential to cause harm.
Michael, the chair loves one-word answers.
Very
so
briefly.
last question with a one-word answer. You mentioned severe or serious adverse incidents early. Maybe for people that are out there that don't understand what they are, they're the potential for people dying. Can I ask this question? With the pressures that we have on our system at the moment, from the health sector through to the ambulance sector, are people dying?
I can't give a one-word answer, Colin, because SAIs are not just about dying. SAIs are about potential harm. So it's more than dying. But are people dying? Well, we are aware of calls that have come in that by the time we get to the person, it is too late for us to help them. What we do not know, Colin, and I have to be clear on this and given the chance to say it, what we don't know is if we had got there sooner, would the outcome have been different? But certainly we are aware of calls that by the time we get there, it is too late for us to do anything about it. These are time-critical conditions. There's plenty of evidence and accepted research that delays in getting to somebody with a time-critical condition and then getting them to hospital for their definitive treatment, there's a link between delay and poorer outcomes.
Thank you, Chair. Thank you, Michael.
Thank you. Paula, go ahead, please.
Thank you, Chair. Thank you for the panel for the update this morning. My first question is really in relation to, I think it's that last point there around sort of the critical time factors. And I'm just wondering, are any conversations taking place with the Fire and Rescue Service in terms of first responders, in terms of some collaborative work around getting to the house and maybe providing the support in the house that then that doesn't require them moving into hospitals? That's my first question.
Yes, thanks for that, Paula. And the short answer is yes. And if the chair likes short answers, I could probably stop at that. But the short answer is yes. We've had a very productive meeting with our fire and rescue colleagues, and Rosie was at that with me just in the last week, where we are exploring a range of areas where they could assist us across a range of conditions. That's at an early stage that I probably I'm unable to elaborate now without going through the proper processes and discussions, but very positive conversations that I would be confident there'll be an outcome from.
Oh, that's good to hear. I'm actually meeting with the new chief in the next week or so that I'll probably hear a wee bit more then. My second question is in relation to...
I'm fairly sure he will confirm that. Yeah.
Great stuff. My second question is in relation to your briefing, which outlined that you said there's the use, because of pressures, there's the use of voluntary and private ambulances to supplement capacity. Could you elaborate a wee bit on that in terms of the protocols and when that happens? Just a wee bit more information, please.
And I will ask Rosie just to take this one, Paula. Thanks.
Yes. Thank you, Michael. Thank you, Paula. Yes, so we have a service framework agreement in place with voluntaries and privates that allows us to engage with them across a range of calls. But we're quite clear on the calls that they can respond to, and we have quarterly meetings with the voluntaries and privates to make sure that there's adherence to the framework. And what we do first of all is obviously looking at our own NIAS resources and seeing if there are any drops in our cover from that and anything we can do internally to improve that cover. Then we look towards our own PCS tier to see what can provide A&E support. And then once we've identified the quantum of the gap, that's when we engage them with our voluntaries and privates to bring that level up to as best possible cover that we can. But it's to respond to appropriate calls in the community.
Okay. No, thank you, and I appreciate just that wee bit extra information. Just a very quick question asked. We've had some presentations from a range of different sectors, and it's just around abuse of staff because these are under so much pressure. I'm just wondering, do you want to speak to that around what the impact that has on your staff?
Yes, well, we see an increasing level of abuse against our staff, and quite surprisingly and very disappointingly, if that's not too mild a term, we've seen that increase during the pandemic. It has a huge impact. I try, or Rosie or a few other senior colleagues try to speak to every member of staff, and I'm always shocked when the response by most staff is, oh, well, it's just part of the job. And my response every time is, it is not part of the job. It is totally unacceptable, and it's always unacceptable, and we try to support them as best we can. But my frustration is there's quite a limit to what we can do, either to support them or to prevent it. We've had a very successful social media campaign over the summer, Stop the Abuse Now. Indeed, many elected representative colleagues contributed to that, and that was much appreciated by our staff. We are exploring the use of body-worn videos, and we'll be looking at how we might take that forward over the coming months in consultation and so on. And there are all sorts of issues around that from a GDPR point of view, but we are also looking at pilots around stab vests. But other than those sorts of issues and continuing to highlight it as an unacceptable issue, I don't know if Rosie has the numbers to hand, but it's in and around 400 or 500 a year. And the impact of that on some staff, the impact seems to be they're able to return to work quite quickly. For others, clearly it causes them real fear returning to work. And we've got a small number of staff who, after incidents like that, are unable to return to work, sometimes because of physical reasons, much more often because of the mental reasons. Rosie, anything you want to add?
Yeah, I've just come in to say that the assumption is, and it is a very worrying trend, but the assumption is that when we talk about abuse of staff, that it's ambulance staff on the road, but it's verbal and physical abuse of staff on the road, but it's also verbal abuse from our folk in the control room taking the calls. And you can understand that people are very frustrated when they're waiting on an ambulance and keep calling back, but we have, for both folk on the road and within the room, we have a range of staff support measures in place, including peer support, access to Inspire, and we have now a clinical psychologist on board that we're starting to work with to support our staff. We have developed welfare hubs where our staff, after particularly stressful calls, either on the phone or out on the road, have somewhere that they can go and have some downtime, and we can have a debrief with them. We staff who are particularly challenged, we have CBT arrangements, so we have a real depth and range of support for our staff, recognising the challenges that they are facing, unfortunately, day and daily.
Okay. No, appreciate that. Thank you very much, everyone.
Okay, thank you. And just to clarify that the chair does love short answers, but even more loves succinct but complete answers and comprehensive answers. And I do understand that sometimes time doesn't allow that, but just to reiterate that if there is further detail that would be helpful for you to send on to us, or the members are looking, that can be done by follow-up in writing. So appreciate that from everyone. I also like succinct questions too, which is great as well. I'm going then to Deborah. Deborah, go ahead, please.
Thank you, Chair. I suppose a lot has been covered there, but I mean, I'm interested in hearing the thoughts in relation to McGee Medical School, and whether you think this will significantly help your workforce in recruitment and retention with, say, the Pacific paramedic courses, and also another question, does the ambulance service believe that their concerns and interests have been accounted for effectively as part of the regional planning and consultation? Thank you.
Okay, thanks. Deborah, I might ask you to elaborate on the second part of that, just to make sure we're answering the right question. In relation to the UU at McGee, the BSc, absolutely fundamental to the future sustainability, but also progression, professionalisation of the ambulance service here. We have got very, very capable, experienced paramedics who continue to serve the population here extremely well and will continue to do. But in line with other countries across, certainly other countries in the UK and Ireland, and other professions, the professionalism of paramedicine is essential, and the enhanced skills that can be got through completion of a BSc programme. I met, along with other colleagues, I met the new intake of BSc students up in Derry on their first or second day, and I have one of the most uplifting days I've had over the last couple of years. I've a long time since I've met such an enthusiastic group of young people who clearly have a long-held desire to be paramedics. We need to get the balance moving forward of how we continue to develop and support our own staff, and they can still, those who are not paramedics or those who are paramedics but not to degree standard can attain that, but also bring in people who are qualified to degree level. But the other key reason, those numbers I mentioned at the start of needing an extra 325 staff in the organisation, our hope is over the next 5 years. The only way we could do it is through the sort of volume that will come in through that programme. We would not be able to train that many staff ourselves. So it's both about numbers, but it's also about enhanced skills and enabling us to move into much more advanced and specialist roles that those people will be well equipped to do. And sorry, the second bit of your question, Deborah, about...
Yeah, so it was, do you feel that the Northern Ireland Ambulance Service have had their concerns and interest accounted for effectively as part of the regional planning and being able to feed into that process?
Yes, we are closely tied into all of the departments' work around looking at priorities, etc. for the coming years. I sit, as do Maxine and Rosie, on relevant groups. I sit on all of the groups that the department have that all of the other trusts are on, like previously the Transformation Implementation Group, now the Rebuilding Management Board. It is, I believe it's very well understood by departmental colleagues and other trust colleagues of the absolutely central role that the ambulance service has in transformation. That if we are going to transform all areas of healthcare, if we don't have an ambulance service that's resourced to get to people quickly and bring them where they need to be, that's a big inhibitor in order to make transformation. I believe that's understood and that the priority in resourcing the ambulance service is accepted. That doesn't mean it's easy, because there's such a long list of very deserving needs, and there's a finite budget, but there's certainly a good understanding. I don't know, Maxine, is there anything you wish to add from the whole planning, linking into planning?
I think you covered it very well, but just to be succinct, yes, we do sit in a range of regional planning meetings that we contribute to. We are able to voice the concerns of the ambulance service and ensure that our needs and our strategic direction is taken accounted for in all of those planning forums.
That's great. Thank you.
Thank you, Deborah. And Jerry Lanneray, Lidahall.
Sorry, Chair, Jerry's not on the call at the minute.
Okay, so I'll move to Carol then. Carol, go all right.
Thank you, Chair, and thank you, panel. It's really important that we heard from yourselves today. I just want to go back on some of the investment. I think we're going to need some more details on the investment into the independent voluntary aspect of ambulance service, because even just my own experience is that they're used quite a lot, and I'm wondering what the issue is, why they're used a lot, and what the issue is around workforce planning. So the other issue I want to talk about is, which has been highlighted in the media a lot, but certainly in the Royal Emergency Department, people are having to wait hours in an ambulance because of the demands in the ED. Have there been any discussions with the department, or indeed any of the health and social care trusts, to have other arrangements where the care of patients are still under ambulance, but ambulances can, within the hospital setting, and ambulances can be discharged to go to emergencies? And then my last question is, it's around, I do think we're going to need more details, particularly on the adverse incidents. So I'm aware of one case where someone died and the family called an ambulance on occasions, and I have no doubt that if there is an inquest, the cause of death will come out, but it will need to be an inquest to establish if an ambulance or even paramedic intervention would have made any difference, because I don't know how anyone can ascertain that detail in absence of an inquest. So, and I also, in relation to the quality impact assessment, given the fact that rural areas have, there's a lot more to cover. So has the ambulance service done a quality impact assessment given the increase in demand?
Okay, thanks, Carol. There's quite a bit in there. I'll try to pick up some. I'll ask colleagues to join with a few brief comments. The investment in voluntaries and privates, the why, it's very closely linked to if we've 20% of our staff down at any point in time, how we fill that. So as Rosie mentioned, we try to get staff to work as much overtime. We look to see, can our non-emergency service do some emergency, and even if they can, their work needs backfilled, so it is largely backfilled. I want to get to the stage, I've said this previously, I want to get to the stage that we are self-sufficient. I don't know whether there'll ever be a point of time where there's not the occasional need for some voluntaries and private providers to fill a gap, but I would like it to be occasional, not every shift. And that is, it's currently the position because of the number of staff we have off, and until such times as we are able to recruit the staff that we are seeking funding for. The issue about delays at ED, you mentioned the Royal, but the issues are exactly the same earlier. Yes, there are hours that patients wait in an ambulance, and I said every day there's 4, 5 and 6 hours. There are sometimes longer. There are sometimes our crews come on and spend their entire shift waiting outside an ED with the patient in the back of an ambulance and don't go to a single call. Lots of discussion with the department and trusts, and indeed the permanent secretary issued a letter last November, just over a year ago, being very clear on the responsibility for this lay with the other trusts to take patients off so that ambulances were free to go on. But the pressures that are across the system has simply made that not possible. We do, however, have an arrangement where we can release people. I'll ask Rosie just in a moment to pick up the detail of that, and also to say about some of the discussions we're having with trusts about alternative arrangements. The last point I was just going to make about the rural areas. We consulted over 2 years ago on a new ambulance clinical response model. We did do an equality impact assessment of that, and coming out of that, we've introduced new response standards that are intended to ensure rural areas are not disadvantaged. Before that, our targets, if you like, for responding were just an average, and the average could be heavily skewed by good performance in a densely populated area versus a rural area. On the back of the equality impact assessment, we have now got targets that there still are average, but there's also 90th centile, and we can only achieve the 90th centile if we're providing a good response right across the region, including in rural areas. But we're currently not able to do that or even come close to it because of the resourcing issue. If we need an extra 320 staff to meet those standards, that's a massive uplift both in staffing and budget. But our intention is to ensure rural communities get as good a response. And we've also got other arrangements such as working with community first responders and so on. But in the interest of brevity, I'll stop at that and ask Rosie just to say something, and again, maybe Rosie to keep it brief, about how we make sure ambulances are released for urgent calls and the alternative arrangements.
Yeah, so thank you, Michael, and thank you, Carol. So we have an arrangement across all emergency departments whereby if we get a Category 1 call in, which is obviously an 8-minute life-threatening response required, and we look within our control room and see that there's nothing currently freely available and the nearest resource is waiting outside an emergency department, we have arrangement with all trusts whereby we will phone into the resuscitation room and what is called their standby phone, or their red phone as they call it, and it is manned 24/7, and we give a very clear message. We have a cardiac arrest call in your locality. The nearest resource is outside your emergency department, and we're requesting immediate release of a crew. And then the staff very promptly try and make space within the department to move a patient in from an ambulance that frees up a crew that we can respond to that 8-minute 999 call. And just in relation to the SAIs, just to kind of to give you some update on that as well, and the work that we're doing with some of the trusts. So in relation to the work we do with the No More Silos regional group, one of the actions from the 10 key actions that were identified was that we would ask the 5 larger, the regions, sorry, would ask the 5 larger emergency departments in the first instance to have dedicated ambulance handover zones that would be available 24/7 for ambulance offload, so we could free crews. It's fair to say trusts have been challenged in the various development, and they are all in different stages of development to get a resolution to that. But that's a work in progress, and we're working very closely with our trust colleagues, understanding the challenges that they face. And your comment in relation to patient outcomes and poor patient outcomes and having an assurance, I'll just refer back to the serious adverse incident mechanisms that we have in place, and that is absolutely escalated through the board and the Public Health Agency. So it's quite a detailed process.
Okay, thank you. So going then, actually I had Pam, I had your name down and then I missed it when I went through that last, so I'll go back to you, Pam, and then I see an indication from Alan. So Pam, please, first. Thank you.
I will forgive you this once, Chair. No, listen, I wanted, a lot of the questions have been asked already, and I wanted just to thank you, Michael, and the panel for taking time to engage with committee today. It is really important. And obviously, ambulance staff, paramedics, and those manning emergency call and control operations are at the coalface of unprecedented pressures facing our health service. So we're just to say that we are indebted to your skills and dedication of the Northern Ireland Ambulance Service. We also fully recognise that securing better outcomes requires systematic change, and that can't be achieved by the ambulance service alone. So I suppose just in terms of commentary, if you want to make a comment, I would be interested to know what you think the Minister should be prioritising in terms of no more silos and changes to urgent and emergency care. So if you wanted to comment on that, and then I don't know if you have any information you could give us on what pathways are available to paramedics, because we know that paramedics do fantastic work, but they don't necessarily have to be placed in ambulances either. They can be elsewhere within the health service. So if you wanted to make a comment on that, thank you.
Yes, thanks, Pam. In terms of areas for prioritising, I certainly think that the No More Silos action plan that the Minister has published focuses very much on the right areas. It's about alternatives to emergency departments. It's seeing who's appropriate for an urgent care centre. It's about planning unscheduled care, people phoning first, etc. But you'll not be surprised, and I do have a responsibility in my role to look across the entire system and to be part of supporting the entire system to do the right things. But you'll not be surprised that I've got a particular interest in the action within No More Silos about prioritising the timely handover of patients. Those handover zones that Rosie has referred to. Sorry, what was the second part of your question?
The second part of my question was around pathways.
Yeah, sorry, I was writing things down and I missed that. Yes, we've seen good progress over the last number of years on the ambulance service being able to do things other than take people to emergency department. If you go back 10 years ago, that was the only option. Ambulance service went out to sick people and brought them to hospital. As our skills have developed, our staff skills have developed, we are able to do much more for patients at scene, either to resolve their condition or signpost them elsewhere. And as a result, we now don't convey about 25% of patients that we go out to. We don't convey 25% of them to an emergency department. That's good for everybody. First and foremost, it's good for patients. I've yet to meet a patient who wants to go to an emergency department, so suitable alternatives, they are keen. It certainly helps the wider system, given the pressures in hospitals and in emergency departments in particular. And it is good for us as a service that we are not joining a queue at an emergency department and waiting. So we're very keen to increase that level of non-conveyancing to ED. As I say, it's currently sitting around 25%. We've got a range of care pathways, and again, I'll ask Rosie to mention some of them, but they're in areas like falls and diabetes and so on. There are areas we could do more if we had access to more care pathways, and also about them being consistent. Our staff do, as we've already said, respond to calls in different divisions. If they happen to be the nearest call, they're sent. If there's a different set of pathways in one trust area than in another, that can make it difficult for our staff to know exactly what's available. So an increased number of pathways and consistent, and I suppose the one in particular that I would highlight that would make a big difference to everybody, not least to service users, is somewhere more appropriate for people in acute mental health other than emergency departments. So that would be one that we could really collectively make a big difference to some patients. And this isn't just about easing pressures, this is about doing the best we can for patients. But Rosie, anything you want to add to that?
I think just if there's no more silos work, just very briefly, some of the other pathways that we're working with trust colleagues, that if they could expand their capacity. So for example, focus on out of hospital care provision, and I use acute care at home as an example in that regard, whereby with a very good service in the community, fairly high acuity patients can be cared for very well in the community, and as paramedics, our crews can refer directly to those services. Some have more capacity in some areas than others, but alternative care pathways and increased ambulatory care provision, whereby we as an ambulance service can hear and treat or hear and refer a patient to avoid that conveyance, so the patients are treated in the right place, which isn't always an emergency department, as Michael has said.
That's great. Thank you very much, and I wish you well. Thanks, Chair.
Thank you, Pam. And Alan, go ahead then, please.
Thank you, Chair. Michael, I certainly don't envy the task of yourself and your team at the moment with those staff shortages that probably come at you at very short notice. I was wanting to ask about the first responder system. Is that still working for you, and is it still a priority, even with staff shortages, to maintain that first response service? And last year here we talked about the possibility of bringing in just drivers to drive an ambulance along with a paramedic, but I think at the time the practice was that it was a paramedic and a qualified technician had to be on board the vehicle. And then I think later you reported that you had got the assistance of some drivers from the other emergency services, even the police and the fire brigade. Now I understand that you have to be careful not to compromise the safety and well-being of patients that are in your care. But are you still using drivers from other services, or is it something that you would continue to give consideration to? Just to try and increase or to decrease the waiting times and get people to hospital in a more timely fashion. Thank you.
Okay, thank you, Alan, for both of those questions. The Community First Responder Scheme remains a priority, and they provide a very valuable service. At the very start of the pandemic in March 20, it was one of the areas that we reluctantly had to stand down, and that was because at that stage, when it was all new in terms of the level of risks and the challenges around protective equipment, PPE, that we could not oversee that those community first responder schemes had access to appropriate PPE, and we had to stand them down. So our control room dispatched them, they alert them to calls in their area. and we didn't do that for quite some time. That has been returned, though. They are back up and running. We are using the community first responders scheme and groups, and I would really pay tribute to the dedication of those individuals who are volunteers who give up their time to do it. We have a small team of staff within the ambulance service, our community resuscitation team, who provide training to, for example, now to teachers, to train CPR skills to undergraduate teachers and to children. They take the lead with training our community first responders. And actually, it's something we are probably likely to look at how we can further develop over the coming years. What other calls could they go to so that they remain a priority? The drivers' issues is a strange one, Alan, because I know even from your question there might sound a bit of a contradiction on what I've said and what we do. It is a case of needs must. So our ideal response would not be to send one clinician with someone who is simply a driver. There are some calls that would be adequate, but there are many calls that it would simply be insufficient to provide the level of care, and there's the need for two clinicians, particularly in things like CPR. If they arrive on scene and somebody has to be doing the CPR while somebody else is preparing, for example, drugs and so on to be administered. It's certainly the case in road traffic collisions, a whole range of areas where they need clinical skills, and one person on their own simply would not be able to respond. But as part of our escalation plan, we have to get to the stage where there's a balance between what is what we would like to do by way of a standard and what's the best thing we can do for the many. So we have been very grateful at various stages during the pandemic when we have colleagues from both the fire service and the PSNI in working alongside. We do provide them training, but they work alongside our colleagues really to allow us to split crews and have more ambulances out, and that remains something that we can request at times, and they can't always do it. There are some times when we need this ties in with particular pressures in those services, for example, around the July time. When they simply have so many pressures of their own, they were unable to help us. But on most occasions when we ask, they are quick to respond. And I suppose that the ongoing conversations I mentioned earlier with the fire service will look at how we can do that on a more ongoing and planned basis. So we're very grateful that they're there to help us when we need it.
Thank you.
Okay, thank you. And Michael, I want to thank yourself and your team there that have attended committee this afternoon, and also to extend the committees, and it's been mentioned by several members, and I want to reiterate it, our appreciation of everything that ambulances staff do in common with our entire health and social care workforce family. They're under huge and unprecedented pressure now for a sustained period of time, and we do fully understand that they are struggling to cope, but continuing to cope and going the extra mile often to do that. And I do want them to know that we understand that is happening. It's not going unnoticed, even though in many ways we're not able to bring immediate solutions. We do realise that staff are stretching themselves to cover all the demands that are on their time. So thank you. Any final words from yourself, Michael, before you go?
Just to thank you for those words, Chair. I will find a way to communicate that to our staff, to let them know that's been passed on. They appreciate those comments, and also from other members. And just apologise again that although you heard their voices, you were not able to see Rosie and Maxine due to our difficulties with technology at this end. But thank you for your continued interest and support in our service. It's much appreciated.
Okay, thank you, and thank you for that, members. So I think again there's a number of pieces of information that have been committed to being sent forward, and the clerk will have a note of that. So if members are content, I'll move on to our next items. Very conscious of time at this stage. Okay, so listen, members, we're going to go then into a closed session to consider a number of items of legislation. Just let me pick up my So what I would need to do then is ask the clerk to pause the broadcasting to allow us to go into closed session for the legislation considerations. Thank you.
No problem, Chair. Just taking a couple of seconds to get confirmation that we're closed. Sorry, Chair, it takes a wee bit longer just on the live stream to close off the streams.
Yeah, no rush, no rush.